Welcome here this morning. We really appreciate so many of you being able to join us in person, and those of you that are joining us online via Zoom, thank you so much. My name is Drew Wilder. I cover Northern Virginia for NBC4 News. Really happy to be a part of this event today and kind of guiding you through this first section. This year's event is called Finding Our Way Back to Mental Health, Designing a More Accessible, Equitable System right here in Northern Virginia. A survey from fall of 2021 indicates that an estimated 545,000 adults right here in Northern Virginia are experiencing symptoms of clinical anxiety or depression, which is a sharp increase from pre-pandemic times. To kind of put that into context, that's 28%. 28% of the adults right here in our community who are reporting these symptoms now after the pandemic. But there are a lot of complex barriers to even accessing basic mental health services. That's therapy, helpful medications, and early interventions. Shortly, we will welcome our presenters and panels of state and national experts for a very candid conversation of the challenges of accessing that basic mental health service right here in our community and what innovative ideas and opportunities might exist to address this critical issue that impacts all of us. It's really important that we address mental health stigma, talk about that, be comfortable with that, find comfortable ways of engaging in that, but it's also very critical that we raise up these organizations who are doing that ground level work. Some of those organizations are here today, and with your help, we are going to work even harder and push them forward and help them do what they do well. So thank you, everybody, for participating in today's event. I'm very glad to be here. We're going to show you a story that was produced for the Changing Minds franchise on NBC4. We aired this just last week. This was in partnership with all of the partners and organizations that are represented today that are hosting this event. Just to give you a little bit of an example about the media's role in discussing and addressing mental health. So we'll show that to you now.
Inside his head, he could feel that something was wrong, but he didn't know how to address it.
And I felt like I was less than. I felt broken.
Robert Johnson would hear sounds that weren't there. Shadows would move. Then the weight of depression came down hard.
I went through a lot of different emotions. I had suicidal thoughts. Lots of times I just felt like giving up.
Feelings that a growing number of our neighbors are experiencing. New data reports that in 2019, about 8% of people in Northern Virginia reported struggles with their mental health. Just 2 years later, that number jumped to 28%.
When people go to get help, they're being confronted with a system that is at capacity or beyond.
Eileen Ellsworth with Community Foundation for Northern Virginia is raising money to support organizations that are easing the burden on the system. One of those organizations is the Trillium Center in Woodbridge.
We model what it's like to have healthy interpersonal relationships, healthy dynamics with other human beings. We're able to model that, and so people know what it's like to have those healthy experiences and be able to set their boundaries in the outer world, right? To be able to be empowered.
Robert Johnson says it saved his life when he came to Trillium 9 years ago. It started with a game of pool, playing pool with other people who were coping with their own mental health struggles. He wasn't alone anymore.
And that's when everything clicked that, hey, you know what? I do have a purpose here.
3 weeks later, Trillium gave him a job. He's supporting himself by supporting others. Reporting in Northern Virginia, Drew Wilder, News 4.
Now we're going to move on and introduce our keynote speaker, Regina James. Dr. James is the Deputy Medical Director and Chief of the Division of Diversity and Health Equity at the American Psychiatric Association. She is a practicing psychiatrist with more than 25 years of experience and has worked on projects and programs that address gaps in minority health and healthcare disparities, including tackling the issue of maternal mortality. Prior to joining APA, Dr. James served in numerous leadership positions, including Chief Medical Officer and Senior Vice President at 2M, Director of Clinical and Health Services Research at the National Institute on Minority Health and Health Disparities, and the Director of the Office of Health Equity at the Eunice Kennedy Shriver National Institute on Child Health and Human Development. In addition to lecturing and publishing about these issues, she is often involved with the design of policy response. Dr. James, welcome, and thank you for joining us today.
So in Northern Virginia, over 500,000 adults are experiencing mental health issues like depression and anxiety. But the point that concerns me most is that many folks do not have access to get the help that they need. And if I can see a show of hands, how many of you know someone suffering from a mental illness? Pretty much everyone in the room. Recent data from the CDC actually shows that between August of 2020, so that was like, the pandemic had already been rolling on since about March, to February 2021, there's been a significant increase that has already been mentioned by Drew in the introductions, and I'm going to reiterate right now. So today what I'd like to do is first open up and talk about why it's important to identify mental illness and substance use disorders, then segue and sort of talk to you about some of the barriers to accessing mental health services. And then a little caveat about how COVID-19 has actually really exacerbated the access, the mental illness and substance use disorders that we are all seeing. And then the consequences. So what happens when people cannot get treatment? And then how are some of the ways might we think about addressing the mental health needs of the community? Early identification, diagnosis, and treatment really can improve the quality of your life, right? It improves your productivity. As you were listening to the man in the previous video who said he basically, didn't have the energy, et cetera, it truly impacts and impedes your productivity. Getting treatment allows you to improve that. Getting treatment allows you to focus better on your daily task at work, at school. It gives you the motivation to get up and do things. You know how it is when you feel like I'm just not into it, I just can't, I just don't have the energy to. Addressing those mental health issues allows you to be able to overcome that. And overall, in general, it just really helps you reach your full potential as an individual. So that's what happens when you actually can get treatment. But what about if you can't? Why can't many people get treatment? There's a number of reasons. Cost is one of the most significant reasons, cost and insurance coverage. Access, whether they're in rural areas or they can be in urban areas and can't access due to transportation. Long waits, difficulty navigating the process of where to even start to identify a mental health provider. Shortage of practitioners who can provide the identification, diagnosis, and treatment. And stigma, which I think was mentioned already. Stigma, shame, and emotional hesitation. So let's start with cost. So on this graph, on the x-axis, or going from left to right, is essentially, to orient you to the graph, are either adults, and then it's broken out into men and women. And on the y-axis, going up and down, is the percent of individuals who have unmet mental health care needs over a 12-month period. So again, looking across from left to right, the light blue bar is essentially college student, early career ages. The darker blue is mid-career and older, and the very last darkest blue is those who are over 65. So the first set of bars is just all adults. So in general, you can see that those who are college age, early career, are the ones who have the highest unmet mental health care needs. But if you break it out into men and women, which are the next two groups of bar graphs, you can see an interesting finding. Again, let's compare the light blue bar for men and women. So you can see that for men who are in college age, early career, they too have a percentage of unmet mental health needs. But for women, the light blue bar, you can see it's significantly higher for those who are in college and early career. So they all are in need, but women tend to have a higher unmet mental health care need. Again, if you look at those who are mid-career, later career, which is the next blue bar, men, again, are experiencing it, but women have a higher level, even at mid-career, later life. Less than earlier on, but still more than men. And the trend continues for those over 65. Bottom line, we are all suffering. Women tend to have higher unmet mental health needs than men. The good news is that with the introduction of the Patient Protection and Affordable Care Act, we did see some improvement in access, right? So the Affordable Care Act passed in 2010. At the time that it was passed, there were 48 million people who were uninsured. But 10 years later, that number dropped in terms of uninsured to about 30. So this is a report, basically, the first 10 years of the Affordable Care Act. Access to mental health care did improve, so that's a good thing. But despite the Affordable Care Act, many are still uninsured, and even those who have insurance often don't have mental health services that are covered, or the co-pays or the deductibles are too high. So again, the good news is that the Affordable Care Act did make a difference, but we still have a ways to go. Now, in terms of access and long waits. So in terms of access, that can be, rural geographically. It can be in an urban area and you just don't have the transportation. So access is a true issue, as well as having long waits. So nearly half of Americans have had to or know someone who's had to drive more than 1 hour round trip to seek treatment. And in terms of waits, 96 million Americans, or about 38%, have had to wait longer than 1 week. And in speaking with a number of folks that I know who are looking for treatment, it's even longer than that. Now, this is a picture for those who have gone to Paris and where the Arc de Triomphe is, there are these 12 sort of streets that feed into the Arc. It's very confusing if you're in a car. It's just very confusing. So I always think of this when I think of trying to navigate the process of getting mental health services. Yes, it's big. It's a big thing right in the middle that seems very obvious to get to, but for some reason and somehow, when you're in that car and you're trying to get to that point, it is the most difficult thing to navigate in the world. And that's what people feel about navigating mental health services and trying to access care. It can be very overwhelming. Where do I start? Where do I begin? And I hear that question all the time. Do I start with my primary care provider, my internist, my family doctor, my pediatrician? Do I look under my insurance if I have insurance? Do I look, and contact my insurance company? Do I look online? Do I get references from friends or family or from a faith leader? It's like, where do I even start to even look for someone? And let alone the question of, where do I start to look for someone who I feel that I might be able to connect with? So, and then when I get there, like, what questions should I ask? What should I share? What do they need to know? So, people are very overwhelmed just thinking about the prospect of looking for a mental health care provider. The process, getting there is difficult. So keeping that in mind, that serves as a significant barrier as well. And then, of course, there's a shortage of behavioral health care providers. And so people living in mental health professional shortage areas, 111 million people live in mental health professional shortage areas. That's a lot of people, 111 million. And this is based on information from the U.S. Department of Health and Human Services. The United States is suffering from a shortage of psychiatrists and other mental health professionals, particularly, again, in rural, urban, and community mental health centers. And those are the centers, or those are the establishments that tend to focus more on those that are marginalized or minoritized communities, or those who are suffering from more severe mental illness. And then there's the issue of stigma. I have this picture here of Dr. David Satcher. He and his team actually wrote the report, Mental Health. And one of the areas that he truly emphasized in terms of barriers to getting mental health services is stigma surrounding receiving treatment. He also noted that another manifestation of stigma is reflected in the public's reluctance to pay for mental health services. So stigma is huge, and we all throw the word around. We know that there's stigma, people don't want to do it, but really don't, really stop and think about and put your head around what does that really mean for each individual? Does it mean that they're just afraid to say that they have a mental illness? Is it that they are afraid to be seen by a mental health care provider? Is it that they're afraid to talk about it amongst their family because they're going to say basically, just, straighten your back, get with it and just get right and just move on, it's no big issue? Is it that they know that they're suffering but they really can't pinpoint anything to say that something is wrong? If you have hypertension, you can actually pinpoint and get your blood pressure taken and say, yeah, I have proof I have high blood pressure. If you have diabetes, you can get, your fasting glucose levels. You can check your hemoglobin A1C and yes, okay, I have diabetes. But when it comes to mental health and mental illness, it's not so easy to identify markers to say that there's something wrong, so people find it difficult to grasp the concept that there is actually something wrong. So what are the consequences? So what happens when someone is suffering from a mental illness or substance use disorder and they actually don't get treatment? There's a societal cost, obviously, right? Loss of productivity, as I mentioned earlier. As a result, there is a study that was looking at the cost of the loss of productivity as a result of two of the most common mental illnesses, depression and anxiety. So it costs the global economy $1 trillion a year without addressing anxiety and depression. So the economic case for investment, if we need to make one, is for every dollar invested in scaled up treatment for depression and anxiety, there's a $4 return in better health and productivity. So there's a return on your investment. So from a policy standpoint, there's a return on your investment. It's better to treat, it's better to identify, diagnose, and treat than it is to have someone with an unmet mental health need. It actually costs society much more money. And of course, there are the individual consequences. What happens to each and every one of us if we are suffering from depression, anxiety, or other mental illnesses or substance use disorder? It interferes with our daily lives. It interferes with our ability to form relationships. It interferes with our ability to perform, whether it's at work or at school. It can interfere with our physical health if there's a comorbid, mental illness along with a chronic physical illness. It interferes with your ability to get better. Of course, then there is overdose, the risk of suicide, and lost work productivity. And I would be remiss if I didn't point out certain communities or certain groups in society that have an extra layer or an extra burden when it comes to unmet mental health needs. Those who are marginalized and disenfranchised are disproportionately impacted by experiencing unmet mental health needs. And these groups include racial and ethnic minoritized communities, LGBTQ+ communities, individuals experiencing homelessness, individuals who are incarcerated, individuals with severe mental illness, with drug addiction, and immigrant populations. And for young people, particularly young people of color, there are significant differences or significant disparities in access and quality of care that is received for mental health and substance use disorders. A significant disparity in the quality. They're more likely to receive less and inferior services, and unfortunately, those who have behavioral problems are more likely to be referred to the juvenile justice system than they are to healthcare providers. I'm sure many of you have heard about the school to prison pipeline. These are individuals who are referred to the juvenile justice system for behavioral issues in school instead of having their behavioral mental health needs met by a behavioral health care professional. We know that mental health needs are on the rise before the pandemic, but once the pandemic hit, that really threw things off course. So in Northern Virginia, before COVID, 1 in 12 adults, that's about 8% of Northern Virginians, had experienced symptoms of mental health disorders. Today, that's about 1 in 4. And we know that the COVID pandemic not only affects your mental health today, but the consequences of what each of us are experiencing today will definitely linger on into the years. And again, what about our young people during COVID and the impact on mental health? I was just actually reading an article yesterday that just came out in JAMA Pediatrics that talked about the rise in anxiety and depression in young people. I think they were looking at between 2016 and 2020, so that was right before the pandemic. And for depression and anxiety, on average, went up about 30%. So that was before the pandemic. So now you have the pandemic and all of the things that go along with that for young people. And keep in mind that bar graph I showed you in the beginning, the women, the girls. So in general, there was, a disruption in the routines. For those who have children or know those who have children, that has been an experience. Disruption in your routines, relationships, the friends that they were able to see, they're more socially isolated. And there was actually an early study that found that students are about 5 months behind in math and 4 months behind in reading compared to before the pandemic. And unfortunately, in terms of emergency department visits, attempted suicides had risen over 50% for adolescent girls. And then what about mental health services? From a global perspective, the pandemic has disrupted mental health services in 93% of countries around the world. And this is according to a survey by the World Health Organization. More than 40% of countries had a full or partial closure of community-based services. In addition, 3/4 of mental health services in schools and workplaces were disrupted, on top of about 60% all therapy and counseling services. So if we had an issue with not having enough mental health care providers before the pandemic, and we were on a rise in terms of mental health and substance use disorders before the pandemic, then imagine what we're going through right now. So how might we begin to think about addressing this issue? Well, I'd like to start with more of the care model, thinking about how we receive our care for those who, underinsured, who are insured, Medicaid, Medicare, et cetera. The collaborative care, let's start with the traditional care model. So the traditional care model would essentially be two people. It would be you, the middle, the patient, and your primary care physician. You're going to your internist, family doctor, pediatrician, or whatever, and saying what's going on from a physical health standpoint, and also maybe sharing, because they'll ask you what's going on from a mental health standpoint. And they will do what they can in the capacity that they can, in the time period that they can, to address your needs. In a collaborative care model, it's actually a team. And so you have two more members, and you have your registry, of course, at the bottom. But you have a coordinator, a mental health coordinator who's there, as well as a consulting psychiatrist. So in a sense, once you tell your primary care physician that you're having these mental health issues, there's a warm handoff, so to speak, so that the psychiatrist can then take on the issues, someone who's been trained as this every day, to really address what's going on with you from a mental health standpoint. So there is a whole person approach to your care, physical and mental. They're connected, they're intertwined. And this approach, this collaborative care approach, it's evidence-based, first of all. But most importantly, it improves access, outcomes, and patient satisfaction. It's very effective when in place. So again, just promoting having this collaborative care model much more common in the mental health care arena could definitely improve access, outcomes, satisfaction, as well as cost, both inpatient and outpatient. Now, I have a series of these slides coming up because I was just so excited when I listened to the State of the Union by President Biden and thinking about the budget that he had mentioned as well, and just the emphasis on mental health in general. I was just so excited about that. But what I'd like to do in some of these recommendations in terms of how to address unmet mental health needs is really sort of highlight what is hopefully on the horizon to address this. So one of the things that was mentioned in the President's FY23 budget was to double funding for primary and behavioral health integration programs. Wouldn't that be fantastic? This is an evidence-based approach that will definitely improve access, improve outcomes, and improve patient satisfaction. So if we can get more funding to address primary and behavioral health integration programs, that would be fantastic. Another way to address mental health issues, how about mental health parity? It's a very straightforward concept. Insurance coverage for mental health conditions, including substance use disorders, should be equal to any other medical condition. So the Mental Health Parity and Addiction Equity Act was introduced, I think in 2008. So, and they have sort of a report card that goes to Congress to say how is it being implemented, what are some of the issues, what are things that we need to address. And so the recent report to Congress shows that companies still continue to violate some of the requirements within the Mental Health Parity and Addiction Equity Act. The good news is that agencies are continuing to try and place more rigorous enforcement of this act, greater stakeholder engagement, increased collaboration to identify ways to make sure that we can support and increase access for mental health and substance use disorders. So we really have to continue to, wave the flag about Mental Health Parity and Addiction Equity Act and the impact that it can have. Again, the FY23 budget proposes to improve parity. So again, wouldn't that be great? In terms of addressing mental and physical health needs, we all have to keep in mind social needs. Some call them social factors that impact health. Some call them social determinants of health, social determinants of mental health. The issue is these are factors essentially that impact us, that are in our environment where we are born, live, learn, work, play, and worship. And research shows that outcomes, 90% of your health outcomes are really due to these environmental and behavioral factors, 90%. So addressing social needs such as transportation. I can't get to the doctor. I don't have transportation. So it's not like I don't want to get treatment. It's not like I didn't want to get a refill on my medication. It's not like I didn't want to necessarily follow up. But if you don't ask the questions and address those social needs, you still may not get where you want to go. Transportation, housing, food insecurity are just a few select social determinants that need to be addressed to help improve mental health outcomes as well. And the Center for Mental CMS has the Accountable Health Communities Innovation Model. And I think it's just really important to, understand what this is trying to do. To address a critical gap between clinical care and health-related social needs of Medicare and Medicaid beneficiaries, such as housing insecurity, hunger, interpersonal violence. Community-based organizations, of course, are eligible and encouraged to apply. And on the map, you can see where some of the accountable health communities are. Again, this innovation model is showing and underscoring that social factors and social needs are a gap. And if you do not address those issues, you're still going to be behind the 8 ball when it comes to making sure that you're addressing the full health needs of individuals suffering from mental illness and substance use disorder. And then just a few extras. Health plans can consider addressing social determinants of health in health insurance benefit designs, establishing incentives to improve the acquisition of health data as it relates to social factors, and, of course, supporting research to evaluate the best approach to integrate financing non-medical services as part of health insurance and benefit design. Again, expanding and diversifying the behavioral health workforce. And I added not only expanding, but diversifying. Research supports that improved health outcomes are seen when there is racial and ethnic concordance between the patient and their provider. So not only do we need to expand the number of folks who are out there who are providing care, but also expanding those who are culturally competent and culturally sensitive to be able to provide the appropriate mental health care that's necessary. Highlighting again, the President's FY23 budget does propose to expand training for behavioral health workforce, whether it's through the National Health Service Corps, Behavioral Health Workforce Education and Training Program, or the Minority Fellowship Program, which I might add, the American Psychiatric Association's foundation is a recipient of that program. So we would be very excited to be able to expand mental health workforce, particularly in psychiatry. And then there is 988 dedicated call-in line. So the 988 system will be dedicated for dispatching trained staff to respond to mental health and substance use emergencies that's now primarily met by law enforcement. And so we have all seen on the news, videos, social media platform, what could potentially happen if the appropriate intervention does not actually come when it's a mental health crisis. And, people are trying to do their best. Unfortunately, we do need mental health professionals responding to mental health crisis. So having this 988 dedicated call-in line will be a significant improvement. And again, according to the American Rescue Plan, the administration has provided $180 million to support local capacity to answer crisis calls and establish more community-based mobile crisis responses and crisis stabilizing facilities to minimize unnecessary emergency department visits. So, and my last piece to really address unmet mental health needs is around telemedicine. So telemedicine has really been a lifesaver during the pandemic for those who could not access, who did not feel comfortable going out, it wasn't safe. Telemedicine really provided a bridge for those who needed mental health services who could not receive them. Just wanted to highlight, as we think about maintaining telemedicine and all the benefits moving out of the pandemic, just some considerations for providers as well as patients. So some providers at this point are using like FaceTime or Zoom to really interact with their patients. Thinking about investment in telemedicine platforms that may be a little more sophisticated than FaceTime and Zoom may need to be a consideration. Also thinking there are, resource-limited health organizations who may not have the bandwidth to achieve reliable internet connection. So just keeping that in mind, particularly for those populations who are marginalized and minoritized and maybe in communities where the health organization may not have sufficient bandwidth. Workflow and training, just keep in mind that those things have to be addressed. Telemedicine technologies can require additional time and resources. And then there are the patient-facing considerations, of course. Just having access to telemedicine may be challenging for some low-income patients and patients in rural areas who may not have reliable access through internet. And so while the use of telemedicine has opened the door for patients to maintain access to care, ensuring quality of care of telehealth visits is still important. So I'm going to close with this. We need to recognize, embrace, and educate everyone that mental health and physical health are inseparable. Because if we don't, the result is going to be continued stigma, discrimination in health coverage, and the list goes on. So everyone, and I mean everyone who needs help should be able to access care when and where they seek it. Thank you very much.
Thank you so much to Dr. James. Really enjoyed that presentation. Now we're going to introduce you to our next speaker, Elizabeth Hughes. Elizabeth is the Senior Director of Insight Region, the Community Foundation for Northern Virginia's Center for Community Research that actually launched back in 2020. She is also the author of the report that you all received this morning, should have been sitting at your table. Those of you who are joining us on Zoom this morning, the Community Foundation team is going to share a link to a digital copy of that report. You'll also get a hard copy mailed to you. Elizabeth has spent her career at the intersection of research and policy, helping decision makers sort through the noise and find relevant, actionable insights to help guide operations, maximize productivity, and achieve strategic goals. Before joining the Community Foundation, she served as a researcher for the Pew Charitable Trust and the Urban Institute. Elizabeth, welcome.
Thank you, Drew. Thank you, Dr. James, and thank you to everyone who is here today for this conference. Today, the Community Foundation for Northern Virginia's Insight Region Center for Community Research is proud to release its companion report to today's event, Finding Our Way Back to Mental Health. And I'm here today to share some of the key findings from that report. Prior to the pandemic, around 8% of the adult population in Northern Virginia was experiencing active symptoms of a mental health disorder, around 150,000 people. And 1 year into the pandemic, those rates had skyrocketed to 39% of our adult population. It's about 600,000 additional adults in Northern Virginia experiencing these symptoms. And they've only leveled off slightly as of fall of 2021. 545,000 adults are experiencing symptoms of a mental health disorder. But what do we mean when we say active symptoms of a mental health disorder? And Dr. James alluded to some of these data, but every 2 weeks or so since the beginning of the pandemic, the US Census Bureau, in collaboration with the CDC, has asked a representative sample of Americans 4 key questions about how they're feeling. These questions are by no coincidence the exact same questions that a clinician would use to screen for clinical levels of anxiety and mental health. They ask how frequently somebody is experiencing tension. Were they nervous, anxious, on edge? And how frequently they felt excessive, uncontrollable worry. When these feelings happen frequently enough, they are a positive screen for clinical levels of anxiety. And in Northern Virginia, around 1 million adults, which is more than half of our adult population, reported feeling tension at some point in the last 2 weeks, and 14% felt that way nearly every day. Worry is just a little bit smaller, 870,000 adults, which is 45% of our population felt worry, and 11% reported feeling this way every day. All told, those symptoms together, 24%, around a quarter, are experiencing clinical levels of anxiety as of last fall. The census also asks about loss of interest or pleasure. And I don't know how to pronounce this word, but I assume that somebody on our panel will be able to inform me later. I believe it's anhedonia, which is this feeling of ennui and losing interest in things that you once enjoyed. That, coupled with sadness, so feeling down, depressed, hopeless, a sense of despair, represent a positive screen for clinical levels of depression. And in Northern Virginia, 770,000 adults reported feeling one or both of these feelings, and around 18% meet the clinical threshold for depression. Together, anxiety plus depression are what we're talking about when we say a mental health disorder. I'll add a note here that these estimates don't include children and youth, which, as we've talked about, are experiencing mental health needs that are acute and different from adults, but are very high. And they also don't include anyone who is institutionalized or would have trouble completing a survey. So individuals with serious mental illness, those that are homeless or incarcerated, are going to be missed from these numbers. Make no mistake, these needs are acute and pervasive throughout our region. As we saw from this room, it's no family or household is probably untouched from these, but we also know from the data that certain populations are feeling these things especially. Demographically, and I don't know if everyone can see the little numbers up there, but age is at the top, and as Dr. James mentioned, this group of young adults appear to be experiencing rates of mental health disorder at much higher rates than any other category. So about 1 in 2 residents of Northern Virginia between the ages of 18 and 30 are showing clinical levels of anxiety and depression. The same is true for individuals who identify as LGBTQ+. About 1 in 2 of that population is experiencing clinical levels of anxiety and depression. By race and ethnicity, the rates are a little bit closer, but we see that the Hispanic population, which is the bar at the top of the bottom coupling, over a third of that population is experiencing those needs. We also looked at economic factors. We looked at household income, self-reported difficulty with paying monthly expenses, which is in some ways a more accurate measure of self-sufficiency because it's not based on income, it's based on how well you're thriving. And then loss of income or employment recently. And we see a positive visual relationship between income and mental health, that those with resources that are not experiencing difficulty paying their monthly bills are not fine, but they're slightly better than the population that are experiencing very acute financial need. So we see that among those who report it was very difficult to pay their monthly expenses, 2/3 were experiencing a mental health disorder. It's a very, very high rate. Not every person who has these feelings of anxiety and depression needs or wants to seek out help from the mental health system. And in fact, our panel will probably get into some of the reasons why people don't even seek out or want help in the first place. But we looked at those that do. We looked at the 370,000 adults in Northern Virginia who specifically want some form of psychotherapy or counseling, and found that of those who want it, 40% are not able to get it. Why? And the bulk of our report is actually focused on these barriers to individuals getting treatment. The data my right, show data from the 2019 National Survey of Drug Use and Health, which asks individuals who have a diagnosis of any mental illness who aren't getting help, why they're not getting help. And I'll read the charts as well as I can. The top reason is cost. And I think our panelists will talk about this. But there's other ones too. We know that individuals may struggle to see results, they may struggle knowing where to look and finding a provider, and they may struggle with even asking for help. So our report boils down these 10 or so factors into 4 common links. The first one, people struggle to ask for help. That is, they struggle to identify their symptoms and to combat the personal and professional risk associated with seeking treatment. As a result, many individuals avoid the mental health system completely and seek out the help of trusted wayfinders. And Dr. James mentioned this before. There's primary care physicians, there's members of the clergy, family and friends, anonymous helplines. I think she used the analogy of the l'Arc de Triomphe, where you're taking different paths to there, but a lot of individuals get stuck in the loop and they never actually make it to the sightseeing. There's a lot of attrition in getting from these wayfinders to a mental health professional. Second, people struggle to find a provider, not just to find any mental health professional accepting new patients, but one that represents the right fit with who they are, what they are experiencing, and what they hope to get out of treatment. Third, people struggle to manage the cost and logistics. My analysis revealed that half of therapists do not accept any kind of insurance in Northern Virginia, with the going rate for self-pay at around $215 for a 45-minute session. Last, people struggle to see results. Treatment has been shown to temporarily reduce symptoms of anxiety and depression for many, but results also vary based on treatment compatibility, patient adherence, which is sticking with therapy, and provider quality. We know the need is great, and our report offers ideas on how our community can lean in to begin addressing these barriers. That's what the second half of today's program is focused on. How do we respond and help Northern Virginia find its way back to mental health? Thank you.
It's wonderful to see you all. It's wonderful to be here. My name is Eileen Ellsworth. I'm the president and CEO of the Community Foundation for Northern Virginia. And we are delighted to have you here today to discuss this important topic. And we've just heard some absolutely shocking data on the extent of the mental health, of the need for mental health services in our region for things like depression, anxiety, PTSD, and panic. I mean, things that so many of us suffer from. Clearly, there are major issues with the system. And after 2 years of a kind of collective trauma that we've all been through, so many more of us are turning for help to an already strained system, a system that is at or beyond capacity, that is inadequate for the demands of the moment. So to help us understand the mental health system across the Commonwealth, and in Northern Virginia in particular, and what possible solutions may exist to reform the system, I am delighted to welcome our first panel of this morning at our event on systems change. And these are 4 amazing professionals, wonderful professionals that have dedicated their entire lives and careers to working to understand the public and private mental health service delivery systems and figure out ways to make them better and more responsive to our needs. So as we chat here in person, as some questions may occur to you, you're going to find some index cards at your table. Oh, and also, I wanted to mention, there are about 160 folks here today in person. There's another 160 folks attending our event online. So we have 320 attendees today. And so for those of you in person, please use the index cards in the middle of your table to write down the questions that may occur to you. And for those who are online, and welcome to you too, of course, drop your questions into the Q&A, and we'll take them as they come at the end of our questions. So we are gonna reserve the last few minutes of the panel for some audience questions. I really would like this to be an interactive event as much as possible. So even in a space like this, let's see what we can do. So let me first introduce our panel, and I'd like to start with Deborah Oswalt, and Debbie is the Executive Director of the Virginia Healthcare Foundation. And Debbie has spent most of her professional career working to expand the scope of health and mental health services across the entire Commonwealth, especially for those who struggle the most to access them. She's an extremely skilled advocate and policy professional in the field. Welcome, Debbie. Next, we have Dr. Naveed Rashid, and Dr. Naveed is the medical director of the Northern Virginia Mental Health Institute. That is a residential psychiatric hospital that is part of the state-funded system. He therefore has a bird's eye view of the existing public system and has some tremendous insights into its strengths and weaknesses that he's going to share with you all this morning. Welcome, Dr. Naveed. Next, we have Sandy Chung, and Sandy is a local practicing pediatrician, and you're wondering, what is a pediatrician doing on our panel? She currently serves as the medical director of informatics at Children's National Pediatric Health Network. Sandy joins us here today because she almost single-handedly launched a program called VMAP, and you're going to hear more about that from Sandy later, which stands for Virginia Mental Health Access Program. And what that program does is it helps primary care physicians like her take better care of children and adolescents who present with mental health needs. She is a bona fide and highly effective citizen activist. Sandy, welcome. And finally, we have Darcy Gruttadaro. Darcy is the director at the Center for Workplace Mental Health at the American Psychiatric Association Foundation. And as such, Darcy has many insights into ways employers can improve the mental health of their workforce. Welcome, Darcy. And finally, we are missing our fifth panelist this morning, Dr. Jermaine Lewis. She is the Dean of the College of Health and Human Services at George Mason University. She was scheduled to be on our panel this morning, but she called us yesterday and she's had an accident and can no longer join us. She's in bed, she's joining us online, she's going to be fine, but she couldn't be here today. So Jermaine, I know you're listening and we miss you and we wish you a very speedy recovery. All right, full bios for all of our panelists are in the program. So let's get started, and you're just gonna hear my voice for a little bit more because I was designated to describe the system. And I'm gonna try and frame that out for you, all right? For you, the audience, because the system is complex and it interacts with professionals in the private sector as well, so please forgive the brevity, please forgive the lack of nuance. I'm going to do my best here in 60 seconds or less to describe the system. When we say the public system, we are referring to the public mental health system of care in the Commonwealth of Virginia. It primarily focuses on serving the seriously mental ill and those in crisis situations. To that end, there are 9 state-run psychiatric hospitals for inpatient treatment. Dr. Naveed runs one of them here in Northern Virginia. And there are 40 community service boards, or CSBs, that are also part of the public system. All of those institutions are focused on crisis. But let us not forget that the state also pays for basic mental health services through Medicaid, and that is a huge program, and also through some special smaller programs like VMAP that I just mentioned, and you'll be hearing more about some of those this morning. Now, in addition to the public system, we also have, of course, licensed mental health practitioners like psychiatrists and psychiatric nurse practitioners and clinical psychologists, clinical social workers, and professional counselors. They work in private practice or for nonprofit organizations, or they work in hospitals and are not a part of the public system. However, the private systems, private hospitals and the public system, there's an interplay. So sometimes private hospitals have contracts with the public system. All right, that's it. But just keep in mind, the public system is primarily crisis-oriented with the exception of Medicaid, and the private system is in business. Okay? So with that background, let's start with question number 1, and I'm going to start with Dr. Naveed. So from your respective vantage points, we're going to talk about first the challenges to the system, and then we're going to take a whole segment of this panel to talk about potential solutions. So Dr. Naveed, you are the medical director of one of Commonwealth's 9 state psychiatric hospitals, and therefore you know the system well from the inside. And the state hospital you run offers inpatient psychiatric treatment for extended stays It exists to clearly address crisis. What, in your view, is the state of the public system?
Good morning. All right, before we get into that, I think it might be useful to do a little bit of additional framing, right? And part of the issue is when we talk about the system, right? And when I was first asked to do this, I was sort of getting lost in all of this myself, and so I tried to take like 100 steps back. I think one of the problems discussing this whole issue is that too often, I think mental health or mental illness or whatever, is thought of as sort of a monolithic entity, and it is not.
Right.
And the presentations and the needs are so diverse from one end to the other that I think without an appreciation of that, it's very difficult to have sort of a coherent conversation that's practical. So if we think about, you want to think about it on a continuum, right? I mean, on one end, you have people that may not even have a diagnosis at all. Maybe there's a issue of life stress or circumstantial or situational factors that are causing some sort of a transient period of distress or what have you, right? And then all the way on the other side, you've got people with chronic severe mental illnesses like schizophrenia, like severe bipolar disorder, things like that, who are more likely to be in and out of hospitals and things like that, right? So that's all the way on the other end. And there's a whole group of people in the middle, right? And the needs for all of these are going to be very different. And the group of people in the middle, I'm just going to take a guess, without any statistics in front of me, but what are we seeing mostly in the middle? It's depression, anxiety, trauma disorders, and substance use. I'd say that's probably most of the middle, right? Where some of those folks are going to be more on the milder end of the spectrum, and some of them, their issues may get to the point where hospitalization or something like that is required, right? But it's not a monolithic system. So when we talk about monolithic, when we talk about cancer, right, there's not just one thing called cancer. There's all different kinds of cancer, and they all have different treatments and different prognoses and everything like that. Mental illness is no different. And I think too often we oversimplify this conversation, which makes it difficult to talk about what part of the system we're actually referring to, right? Because they all need different things. On this end, supportive counseling, therapy, community services, that might be sufficient, right? And much of that may not even require a mental health professional, right? I mean, it could be something that you could obtain through your local community, local church, whatever. In the middle, probably most of those folks need some sort of outpatient treatment, right? Which again, may or may not require medication, may or may not even require a psychiatrist. I think there's a huge gap in the middle there for people to find, as the data pointed out, outpatient, providers, therapists. It could be a psychiatrist, it could be somebody else, somebody to talk to help at least get a starting point. There's a lot of times where I've seen somebody on the outpatient side, and I'll see them and I'll know immediately that they need a therapist, and I'll try to make that connection. Other people will have seen a therapist for 10 years because they're dragging their feet at getting on medication. Finally, they're convinced to go over to see the psychiatrist. So there's no one right way to do the part in the middle, but having a good entry point, I think, is really important.
Yeah.
Now, what I do is more on this side, right? So this is the state psychiatric hospital, so this is when things really fall apart, right? And when we talk about outcomes, we can talk similarly about a range of outcomes, right? So it's not monolithic, right? On this side, maybe the outcomes are you have a diminished quality of life. Maybe you're still able to work, you're still able to function, you're still able to parent, but you're doing all those with sort of a diminished capacity, right? You're not able to enjoy things in your life. You're not able to be the most effective worker, spouse, parent, what have you. Then you sort of move to the middle. Now you're starting to talk about people that are having trouble working. Maybe they're taking more time off of work. Maybe they're having trouble keeping a job. Maybe they're running into other kinds of functional difficulties to where you're moving from quality of life into, real symptoms that are interfering with your ability to function. And then when you move over to this side, that's when things really start breaking down. Then you start talking about things like hospitalization, crisis interventions, for a certain segment of our population, incarceration, right, which can directly be a result of untreated symptoms, sadly, and death via suicide, overdose, or some other thing, right? And so the state hospital system, the public system, primarily functions on this side. I don't know if
and
that's
by this
necessarily
side, you mean the crisis side.
the crisis side, right? And so as a state hospital, who do we see? We see patients that are in imminent severe crisis. Our patients, 99% of them are not there by choice. The patients at the Institute and just about every other state hospital in this state, they're either there due to a temporary detention or an involuntary commitment, or because they're referred from the jail or something of that nature. So these are the folks for whom things have truly broken down, completely broken down to the point where there is a real risk to themselves or others, so on and so forth, right? And so if we just focus on that end for a minute, some of you may know this, we have been in the midst of a state hospital bed crisis for several years now, which means what? All the beds are full. Well, then you ask, well, why are all the beds full? One answer is, well, there's just not enough beds, but the way I see it, you keep increasing beds and they'll just keep getting filled, and it remains this sort of very crisis-oriented, hospital-dependent system. So sometimes we like to think about the front door and the back door. So at the front door of the hospital, what are the things that might help somebody not be hospitalized? What are the things we could do to divert or to mitigate the possibility of a hospitalization?
So we're going
right?
to get to that question in the second
Sure.
the second half. So
Okay.
that's great, Doctor.
Great.
Yeah, that's great.
And then on the other side, the backdoor side, when we're ready to do discharge planning, why are some of our patients staying in the hospital so much longer than they need to be?
Yeah.
We have patients who probably have met criteria for discharge and they're still sitting in the hospital months later.
Gee.
Months, sometimes years even. Why? Where do they go? There aren't enough, just name it, supported housing programs, group homes, assisted living, whatever kind of, even shelters. There aren't even enough of those. And it's a shame that we would even have to discharge to shelters. But even when we do that, there aren't enough of them. So then there's a backdoor issue, and that's just housing. But what about treatment? There was a statistic in there about how X number of percent had to wait more than a week to receive mental health treatment, right?
It's a lot more than that now.
It's a lot more than that, but let me ask you this. When somebody discharges from the hospital, some of those are the most vulnerable people in our community with the most severe mental illnesses, with the most number of sort of social determinants working against them. And a lot of times we're lucky if we get an appointment for those folks within 2 weeks.
All
and
right.
sometimes more.
So let me make sure I get to the other panelists too. Thank you so much.
I can keep going.
No,
That's
I know,
just,
that's very
just the tip of the iceberg.
Very, very good. So let's get to Dr. Sandy Chung right now. So Sandy, as I said in your introduction, you're a pediatrician, a primary care provider. You were never trained as a mental health professional, but you saw a tremendous need and you decided to try and do something about it. From your vantage point, you're treating children, you're treating adolescents. Do you think the state or the private system of mental health care delivery in Northern Virginia is working for children and adolescents?
Well, thank you for the excellent question. If he's at the acute crisis end, I'm before the before. Right, and so as we know with pediatric illness and mental illness, that actually all mental illnesses, about half start before someone turns 14 years of age. 75% of mental illnesses start before they turn 24 years of age. So very much if we think about sort of the very upstream interaction and where can we make a difference in the long run, it's really in the childhood population. So before it becomes a crisis, well before it develops into severe mental illness. Some children will have that happen regardless, but there are many places where we can intervene earlier. For example, I'm a pediatrician. I'm in Fairfax, Virginia. I run a very large group. I'm CEO of a pediatric practice that has 120 pediatric providers in 22 locations. So we treat a lot of children in Northern Virginia. And what we found is that when we went through our training, we were taught to refer kids that we screened, and we were worried about anxiety, we were worried about depression. We were taught to refer those patients to psychiatry, to child psychiatry, psychology, therapists. But what we were finding is the wait list was 4 to 6 months long. So when you have a child and as a parent of a child, I have 4 children, as a parent of a child, if you're unable to get your child to get out of bed, if you're unable to get your child to go to school, and you have to stay home because you can't go to work and leave your child at home in this condition, right? You just absolutely can't do that. And you need to do that for 4 to 6 months and not go to work. That's a problem. Mm-hmm. Not only is that a problem, but your child is suffering. And every parent, anyone who knows a child, anyone who was a child, you know that as a child, you don't have the resources, you don't have that capability, and you need a caring adult to help you. Mm-hmm. So as we think about how to intervene in the long term for mental health issues, focusing on children and focusing on this before it becomes a problem. The good news is that adversity is not a destiny. So we are able to impact this so much earlier. We're able to make a change if we do an intervention earlier in life. We know from early childhood brain development that if you do something for a child before they turn 3 years of age, you can impact their adult health outcome. We can actually prevent long-term chronic disease if we help to take care of children and we focus on kids before they have these permanent long-term conditions. All of us have been through a crisis in the last 2 years. All of us have been through a trauma. And if we think about children and that impact of that trauma and the lifelong consequences of that trauma over the last 2 years, we really, really are at this critical point where we need to focus on kids and focus on what we can do to help them, because our next generation is at risk. So that being said, we're going to talk about solutions in the next question, and I'll tell you more about BMAP. But I think as we're thinking about this issue, absolutely there's an acute current crisis at hand for adults, but make sure that we remember, what's happening in children. The issues related to mental health access for adults is even more so for kids. When we surveyed our pediatricians in Virginia over the last couple of years, we found that 90% of our pediatricians are seeing an uptake in anxiety, depression, behavioral conditions in kids. 90% of them. So there's no question that we're seeing this in our community.
It's good to have that data point. There's so little data about the mental health needs of children that we could even access for our study or for this event. So I only know 2 things. One is for every 5.5 psychiatrists that are trained to treat children and adolescents, there are 10,000 children. So that's a huge service gap. And the only other study I think Elizabeth was able to find pertinent to children was one that said in April of 2020, insurance claims for adolescents had doubled year over year. And that was like a month and a half into the pandemic. So does anyone have any insight into why there's so little data about children? We know that they're suffering at greater rates than adults, but we don't know to what extent.
Well, one of the challenges with children is the privacy concern. So doing surveys and calling up families and asking about their children, we certainly could do that. However, obviously with children, we're extra cautious about privacy, especially in that adolescent time frame. We talk about stigma, certainly, but I think the reality is that there are ways to get studies, so there are some studies out there, and nationally we know that there has been probably a 30 to 40% increase in mental health conditions in children. 1 in 5 children have a diagnosable mental health condition, and so it's actually quite common. What we do know, though, as far as psychiatrists, there's a shortage, but when you look at child and adolescent psychiatrists, there's even more of a shortage. Exactly. In fact, most of our state doesn't have a child and adolescent psychiatrist at all. And the ones that are available, many of them do not participate in insurance, and so when that happens, then they may as well not be accessible for a large portion of our population.
Well, that's a great segue into Debbie Oswald. So, Deb, you are the executive director of the Virginia Healthcare Foundation, and you've spent many years engaging across the entire Commonwealth on policy. What is your opinion about the accessibility and affordability of basic mental health services in the Commonwealth?
Well, good morning, everyone. So I think so clearly there is not enough access to basic mental health services or to mental health services for the seriously mentally ill or all along that continuum. I love your continuum, doctor. And so one of the things that we've really focused on most recently at the Virginia Healthcare Foundation is trying to understand what is behind that. And it actually, while there are many complexities to all of this, the thing that I think is at the core of it is the shortage of licensed behavioral health professionals throughout the state. And to get a better handle on that,
we just recently did an assessment of the capacity of Virginia's licensed behavioral health workforce. And some of the findings were actually shocking. Now, you just got data earlier from about what's happening here in Northern Virginia and the shortages that you have here. I have to tell you that Northern Virginia has so many more behavioral health professionals of every kind than the rest of the state. So with the challenges that you're having here, with as many professionals as you've got, just think about the rest of the state. And all of that leads to some of the national data that really shows Virginia's very low ranking in terms of availability of mental health services. We rank 39th. We also rank 39th in terms of the number of behavioral health professionals per 100,000 population.
Wow.
When Dr. James talked about the mental health professional shortage areas, 93 of the 133 localities in Virginia are federally designated as mental health professional shortage areas. And 40% of the population of Virginia lives in those areas, compared to 30% of the population nationwide living in mental health professional shortage areas. So we have work to do everywhere. Some of the most startling data is that we actually have 2 localities in Virginia that have absolutely no behavioral health professionals of any kind. And we have 2 others which have 1 FTE or less of any behavioral health professional. We have 54 localities that have no psychiatrist, and another 25 that have only 1 FTE of a psychiatrist or less. And then, just to scare you to death, because it certainly brought that reaction to me, and I have found it very motivating, that 61% of the psychiatrists in Virginia are age 55 and older. So we already don't have enough, and now we have a very aging workforce. And that's not to mention, I'm so glad that Dr. James mentioned the diversity of behavioral health professionals as well, because we're sorely lacking in that area among all 5 licensed behavioral health professionals as well. So those are just, so yeah. I think everything comes down to workforce. And I know we've heard about, we talk about the costs related to getting mental health services, and that several people have mentioned that so much of it is a cash-only situation up here, and really other places too. And I think that has to do with workforce. I know there are insurance company issues and parity and all that, but in the end, because there are so few behavioral health professionals to meet the overwhelming demand, it's a seller's market. They don't have to take insurance, and that's why they don't. It's cash. And so even if you have a good health insurance policy that covers mental health in a robust way in many, many places with many behavioral health professionals, it doesn't matter. And you need to have cash.
And Debbie, you helped me understand something about the gauntlet people have to run in order to become a licensed mental health professional. It is
therapists.
It's terrible. I mean, there's like 3,000 hours of supervised clinical work you have to somehow figure out and pay for yourself. I mean, it sounded to me like it's a system that's designed to get what we're getting. Not many people make it through the gauntlet.
Well, and that's referring to MSWs and Masters of Counseling graduates who want to move on and become licensed clinical social workers or licensed professional counselors. And there is a financial gauntlet that many have to run. I'd be happy to describe it, but I'm aware of the time.
Right, yeah. Let me get to Darcy, and then we do want to leave a final question here for it. Now that we have a deeper understanding of the issues, what might we suggest going forward? So Darcy, you are the director of the Center for Workplace Mental Health at the American Psychiatric Association Foundation in Arlington, and as such, it's your job to make the business case for workplace mental health and help raise awareness around the criticality of employers acknowledging and embracing the importance of mental health in their workplace. You also had a prior distinguished career with NAMI, where you were the director of policy. NAMI stands for the National Alliance on Mental Illness. So from your role today, what do you think is the primary challenge for employers in obtaining quality mental health care for their employees?
Yeah, I mean, I think, good morning, everyone. Great to see you all. Great to be in a room with people. I haven't done that in a while. I would say, of course, employers are concerned about mental health, probably at the highest rate they've been in a very long time, because they know the numbers are ticking up. I think Elizabeth laid out so well what the CDC has been tracking in a tripling and quadrupling of people experiencing symptoms of anxiety and depression. And those issues impact performance, productivity, and of course retention now, because we know there's real concern about keeping high performers. So there's a real focus now on workplace mental health and what employers can do. And we speak with companies across the country, with benefit leads who say, I get calls from people who've made 40 calls to find a provider for a family member, maybe it's a child, for themselves. So I would say the key really that we've been advising businesses on and that they're getting much more engaged on is the reality that we don't have just one model. It's not, if you have a mental health condition, you get referred out to a specialist. We have other options, and I think the continuum was described so well. For many people in the moderate to mild segment of experiencing mental health conditions, they can be treated in primary care. And we don't have to necessarily refer them out to specialists, but we certainly need to provide support to primary care providers. And Dr. James described the collaborative care model, which has more than 80 randomized control trials supporting it. It's a model that really works, but the challenge is try to find that in many communities, and you won't find it because there has not necessarily been the support that primary care practices need to understand how to change their workflow. It sounds simple enough. You just bring in a team and there you go. You're operating with a collaborative care model, but in fact, it takes an investment in understanding how to change those workflows, how to set up a registry, how to do the screening in primary care. What we know right now is that in this country, it's 8 to 10 years from the onset of a condition until people get care. And that is where we go way off base in having people end up on the end of the continuum they shouldn't necessarily be on. So employers are getting more engaged, they're asking more questions of their health plans, and when we talk about a cash system, we have multiple studies showing psychiatrists are paid 20% and more less than primary care providers to deliver the same care, same CPT codes, same care delivered in primary care, and yet they're paid 20% and more less. So we really need to work more with health plans as partners to say we need to have more equity in these reimbursement rates. We need to create a system where mental health is not, and substance use treatment, is not a second citizen in the healthcare system when it comes to payment. We know we have these models out there that work. We need to invest in the infrastructure to expand them because integrated care is more an exception in this country. We treat the top of the body, from the head up, differently than we treat the rest of the body. And yet what we know is when people develop conditions like cancer and diabetes, they get depression and they get anxiety, and their outcomes, the cost of treating those conditions is 2 to 3 times higher. So as businesses, when you're looking at your bottom line, just know that if we don't up the mental health system and the treatment delivery system, we're going to pay a whole lot more for people who have chronic health conditions, and that's something that's really avoidable. So So there's a lot of opportunity. I know we're going to talk about solutions, and certainly effective integrated care is one of them.
So it sounds like this bifurcated system of treating the mind and the body separately, training professionals for the mind and the body differently. If that fixed idea gave way to an idea that primary care providers could really be the gateway for both, not just one, that more and more people could get the help they need. Yes?
Yes, can I just cite one stat? We've been working with the University of Pennsylvania, and they have implemented the collaborative care model that Dr. James described. So they routinely screen for depression and anxiety in their primary care center at Penn. They have found 1,500 people in their data who were suicidal, who the primary care provider would have no other reason of knowing that they were suicidal and experiencing depression at that high a rate. So that really gives you a sense of the opportunity that exists when you make screening for common conditions like anxiety and depression part of standard clinical care.
Great. All right, so we have 10 minutes left for the second question. That's about 2.5 minutes per person. So now that we understand the challenges, let's talk a little bit about effective solutions. You may have already expressed them to some extent in answer to the first question, but Dr. Naveed, let's start with you. If you could change one thing about the current system and make it more accessible.
You said 2.5 minutes, I only get one thing? I'll try to talk fast.
Okay.
All right. So,
what would that be?
For the crisis end of the system, the state hospital system, I'd say probably two things. Number one, the state hospital system, in fact, the whole system of hospitalization in Virginia is deeply dysfunctional. The state hospital is supposed to be a safety net. It is supposed to be for those that have no insurance, that are indigent, that are, in dire straits, so on and so forth. It is absurd that right now at our hospital, the majority of patients have insurance of some kind or another. That's absurd. It should not be that way. The system needs to be corrected. There's some legal and other reasons for this that have been problematic for many years now, but the point is, these crisis admissions, people that are in the hospital for short lengths of time, 8 days, 10 days, if the private system was able to manage that population, we would be more effectively able to care for those that really need longer term care. Right now, we're trying to do both and we're drowning.
Yeah.
The other thing on the public sector side is the front door and the back door. What can we do to prevent hospitalizations, and what can we do to help people discharge safely into the community so that there's a flow through? The answer is not more beds, in my opinion, because then you just get stuck in the middle with more bloat, so to speak, right? The other thing I'll say, if I still have a little bit of time, for this sort of for the middle piece, I think you all sort of alluded to this, and I can only speak about Northern Virginia. I don't really have as much knowledge about the rest of the state, but even if you're in a place of relative privilege, right? So these are your options. You can either pay cash, you can either go through insurance, or you go to the Community Services Board, which is run by the county, right? Those are your options. Even if you have relative privilege, right, that first, may not be available to everybody, and you make the point that you might as well take them out of the conversation for huge segments of the population. So you're really dealing with the second and the third, and I really feel like it's maybe that the supply and demand issue, that there's just not enough resources for people kind of in the middle there. And so, some people can pay cash, and that's great. And even if you can pay cash, by the way, there's still sometimes waiting lists. It's that bad. But let's say that you can't, or it's not practical for you, you're really dealing with long waits, and that's probably going to result in, the more potential for deterioration. And the last point is, if you then incorporate the factor of marginalized communities, social determinants of health, anybody who is not in a place of relative privilege, you'll see them go downhill much quicker. You might start off with something that is just a set of circumstantial social stressors, but then when you lack the community safety nets, or when you have community risk factors, you're going to see those people potentially progress much further down the continuum, which is unfortunate.
So Dr. Naveed, when we were getting ready for this panel, you were sharing, your experience in the state hospital where people only come there when everything's fallen apart. And you were thinking about why there weren't more upstream, earlier interventions, right? But if all we're going to fund is crisis, all we're going to get is crisis.
Yeah, absolutely.
Okay. All right, Dr. Sandy, same question for you. How can we provide better mental health care for our children and adolescents?
Absolutely, and I wish I knew the answer to all of that. But I will give you one example.
There's no silver bullet here, that's for sure.
And we've talked about this a few different ways now, about how do we use the rest of our medical workforce, so primary care, to help with this process, because we know there's a shortage of mental health providers. There's work being done to try to improve that will take time. However, today you have pediatricians, internists, family physicians, nurse practitioners, PAs available who can see patients and do work. However, obviously, we weren't trained to be psychiatrists, nor will we ever be. However, there are some things we can do. For example, for children, last week I had patients who came through my office. Half of they were teenagers and school-age kids who had symptoms of anxiety and depression. So half of my day. And that's pretty common now. Whereas we used to treat sore throats and ear infections, we have now turned into mental health providers.
You said about half of your patients?
Yes. Yeah, in a day when they come into our practice, that's right. And so what happens there is that a pediatrician is now seeing your child, and trying to help you. Well, how do we do that effectively? And so VMAP, or the Virginia Mental Health Access Program, is designed to do that. It is a statewide program where we have worked with pediatricians, trained them. We've provided over 15,000 hours of training in the last 3 years to teach primary care providers how to do this work. Not only have we done that, but we provide them a phone number where they can actually call and speak to a child psychiatrist. So this is the primary care provider, calling and speaking to a child psychiatrist to ask for assistance on what to do with this child and family in front of them. Within 30 minutes, they can talk to someone for help. When I have a question about a child with a heart issue, for example, I can pick up the phone and speak to a cardiologist right away. And they typically will either see the patient that day or see the patient the next day if they're concerned. So they'll help me right away. In psychiatry, that's not the case. There aren't enough child psychiatrists to do that work, and they're busy. They're busy seeing children right now. So in order to make this work, we had to provide a statewide phone number where anybody seeing a child in the state of Virginia can now reach out and talk to a specialist, treat that child right in front of them within 30 minutes. We've treated over 2,000 kids and reached over 1 million children through training over 500 pediatric providers. So.
Amazing. You know, I have a friend, I was telling her that we were doing this event on mental health, and she's the mother of a 12-year-old, and she said to me, if my son broke his leg, I'd know where to take him. But if my son came home and said, I'm sad, I don't have any friends, and was showing signs of not wanting to get out of bed or low energy, she said, I wouldn't know how to take him. And yet bones knit up pretty good in a 12-year-old. But the second thing is actually a threat to his life. And I wouldn't know where to take him.
Right. We want her to take him to his pediatrician.
Yeah, getting the primary care providers in this, I think, makes a lot of sense because we already know you and trust you, yes? Yeah. So before I ask Deb the same question, if you have any questions, please write them out on your cards, and community staff foundation staff will come around and collect them, all right? So Debbie, your turn. You've got this wide, Commonwealth-wide lens to this question. If you could change something about the current system to make it more responsive to our needs, what would it be?
Well, you know that I am going to say we would increase the number of licensed behavioral health professionals.
Exactly.
And the good news is that as terrible as the situation is now, there are actually ways that we can dramatically improve it. And some of those are underway as we speak. We need more psychiatric residencies in Virginia, and the General Assembly is considering that now. Senator Favola is here, and yay, Senate, that included the funding for that in their budget. We're hoping the House will eventually see the light on that. We also need child and adolescent psychiatry fellowships, which is something that it just takes money and working with the right institutions. It's not even expensive. And to have those, but we know that where the fellowships occur is often where the folks who are trained as fellows end up staying and practicing. And so that's helpful. The issue that Eileen just raised a few minutes ago with MSWs and Masters of Counseling folks who can't run the financial gauntlet of paying for the required supervision of their clinical hours is being addressed. Unless something really weird happens in the state budget, both the Governor Northam and the House and Senate included $3 million for a pilot program that we would actually administer from the Healthcare Foundation to pay for the supervision fees for 100 each of MSWs and Masters of Counseling students, with priority being given to those who practice in mental health professional shortage areas, who are bilingual and or who are people of color, so that we can try to make headway on a lot of fronts. In exchange, they simply need to practice for 2 years as that licensed professional once they make it through the gauntlet. So there are things, and these are just a few things being done now. We as a grant maker are also funding some things that are helping increase the number of licensed behavioral health professionals. There are more things that can be done, but I know I'm out of time.
Debbie, thank you so much. Debbie taught me more about this topic. I got to tell you, I told her she ought to be a kindergarten teacher because she explained it to someone that knew nothing. And I felt like when the conversation was over, I could kind of sort of talk about it. So Debbie, thank you. So Darcy, you get the last word. What if you could change one thing about what employers do around mental health benefits for their employees? And you may have already answered this with the collaborative care model, but
yeah,
what would you do?
I think we are providing them with a lot of information on what the model is and why it works so well, and some concrete examples of where it's been implemented well. Blue Cross Blue Shield Michigan, we've been working with, they're providing funding for primary care practices to close for 2 days, change their workflow, get trained on the model. Why is collaborative care so important? 70% of scripts for antidepressants are written in primary care. Primary care is a low stigma setting and people are there anyway. So we really need to invest in programs like the one Dr. Chung just shared, like the Blue Cross Blue Shield model. The reason that Dr. Beecroft, who's a psychiatrist, medical director at Blue Cross Blue Shield, started this is he looked at their outcome data for behavioral health care and saw how many people were going to the ER for what they otherwise needed as outpatient care. When people can't get help with outpatient, they go to the emergency room. And that is really costly for employers. It's costly for the whole health system. It is not a good way, from a policy perspective, to pay for health care. And so he really said, wait a minute, we're paying a huge amount. Every time someone goes to the ER, it's $14,000. Let's think about investing that upstream and really getting our primary care practices in Michigan up to speed. And they are expanding and seeing incredibly great outcomes. And the cost data is really impressive. So it works, and it's just not available in enough places, and it takes a commitment on the part of health plans to invest in the change in the way practice is done, but it's well worth, there's a high ROI on it. So I would say, we have, on our website, workplacementalhealth.org, we have an infographic free to anyone who wants to see it on the collaborative care model, on what employers need to know and what employers can do. So I would just encourage you to take a look at that.
All right, great. So we are going to spend the next 10 minutes taking some of your questions, and I was just handed 5 index cards, and 3 of them have essentially the same question. Is it possible to invest more in mental health, like emotional education in the public schools? Or what can the schools do to help our children? Finally, one word I haven't heard today is schools. Shouldn't teachers and school counselors be better trained for serving and referral options? They're the ones on the front edge of this. So wow, our public schools are expected to do a lot. I'm curious what your opinions are about this question, though.
So as a pediatrician, I'll start. And so, and you're absolutely right. And what we really need to think about is how do we help children where they are? They may be in the pediatrician's office for 15 minutes an hour, but they're in school 8 to 10 hours a day, every day of the week. And so, but what Eileen has said is correct. We're already asking a lot of our teachers. However, having training and having that ability, and that's happening. That's happening in various counties in Virginia, certainly, where teachers are being trained on red flags, what to watch for, what to take care of. But what we really need...
Who is training them, if you know?
Well, there are various organizations, nonprofits, who are training
Okay.
certain schools, certain counties that they've worked with. So Loudoun County, I know, for example, does that already.
So there is one system
They're
up
already
here.
doing that already, yeah. And so, for example, there's suicide awareness happening, education happening for students. But realizing that it does take a licensed mental health professional to help at the end of the day. And so funding for that within schools. Certainly we've made some progress over the last couple of years with increasing the number of counselors in schools settings, but we need to continue to do that work. But yes, I think it's a group effort. This is very much a case where it takes a village.
Mm-hmm.
So.
I did want to mention that we have a program we do in schools called Notice, Talk, Act at School. And we also have Notice, Talk, Act at Work. And these are, as a nonprofit, my colleague works with his team to go into schools, and they've worked with some schools in the DMV area. And it's really to help school professionals notice what are concerning changes in students, not from a diagnostic perspective, but just seeing something that doesn't look right in the way a student is acting or feeling or engaging or interacting, and then knowing how to have a conversation with that student and how to work with the school counselor to really, if the schools are lucky enough to have one, to really connect that student with services. And we have Notice, Talk, Act at Work, which is an e-learning module that has the same idea behind it. It's noticing changes in colleagues, really knowing how to start a conversation, and then knowing how to connect people with care. Because in this country, only 40% of people that have mental health conditions are identified and receiving care. So we have a long way to go to really close that gap. But I just wanted to mention that because we do have this. It is free, Notice, Talk, Act at School, and my colleague is really seeing expanding around the country.
Great.
So I would just add to all of that to mention that there are a trauma-informed approach to, we talk about it in healthcare as to care, but there are growing numbers of localities that have trauma-informed care networks that try to educate it's not just healthcare, but it's bringing a trauma-informed approach to schools, to the police and law enforcement, to the community overall. And those are, at a minimum, you can start there with training to help and to help teachers and school administrators understand the whole notion behind how you identify someone who has experienced a trauma or maybe having a bad day because of a trauma experience the night before, that kind of thing. And there are some really interesting things going on around the country in different states. West Virginia has one where the police and the schools have set up a communication thing where they have a code word for, so if the police are called to an incident in a domestic disturbance or something worse, a shooting or something the night before, and there are children, school-aged children in that home, those kids, could ultimately end up going to school the next day. The police in that community in West Virginia have established a protocol where they'll call and they won't give the details of what happened, but they'll let the school principal know, Susie Q, and then they'll just say whatever that code is, which is slipping my mind now, but but essentially it's just an alert that if Susie isn't doing that well, in school that day, or if she starts to act out or something, to handle her with care. And to understand that there's more going on. And so there's that kind of thing. And then more concrete things are school-based clinics. We have a growing number of them happening in different parts of the Commonwealth that offer mental health services in addition to some health services, medical care, which also helps with the stigma and also helps when they pull in the parents, because then often it's a family dynamic at play.
Well, speaking of the school clinics, does anyone know, either in the audience or here on the panel, if the school nurses that run those clinics are getting more of this training?
So in our region, in certain counties, there isn't a nurse at each school. So despite the amount of resources we might have, we actually do not have a nurse in every school. Often we have a clinic aide or a volunteer parent who's doing that work. So they certainly could be trained as well, but I think that's just a completely different area of advocacy where we need additional resources.
And I will say this, there is an organization that comes to my mind called the Eric Monday Foundation, and Brian and Holly Monday started this many years ago. They are focused on helping coaches in the school systems identify the mental health needs of the kids that are in the sports programs, and then when they identify that they have a need, help them get help. And that's the whole mission of the Eric Monday Foundation, and it's school-based. So thought I'd share that.
If I could just make one more comment about going further upstream in that daycares and preschools and those who are taking care of our youngest children, ensuring that they too are being trained, because we know that one of the number one factor for resilience in a child is having the presence of a caring adult.
And coaches can fulfill that role.
Absolutely.
Yeah,
and then when we're in daycare and preschool, it's those teachers or caregivers that are there. So.
And there's one more question we can get to, but we only have 3 minutes to answer it. So, and it really begs the question of something Elizabeth mentioned when she was presenting her data. The question is, how can houses of worship be a more integrated party into the continuum of care? And I think this person is really asking a question about this concept of wayfinders. You know, not everybody can find their way when they need help directly to a psychiatrist. So who else in our society, in our world, can be trained to spot the issues and help guide folks that need help to the professionals? And certainly, we're going to have a second panel where we're going to talk about the training of the clergy as wayfinders. So I think that's what this question is asking, is, you know, people trust their spiritual leaders as well as they trust their teachers and their coaches. And maybe that's the answer. You just get more and more people attuned to this issue, and the more people you have attuned to the issue, the more chances folks that need help will get it.
Yeah, I just want to mention that my colleague is here who helped develop a guide for faith-based leaders on mental health in the faith community. And so there is a guide on the APA Foundation's website. I think it's there. But it is, and the reason is exactly what the question asks, which is many people do turn to their faith community as a first place. So that is certainly a place to form community partnerships, to help do some training, to help create really important information sharing around how to navigate the mental health system, and even how to provide some just comfort to families at a really difficult time, which we've lived through and continue to live through for many. So yes, that is a really important question, and I'm so glad it'll be addressed on the next panel. And I did just want to mention that the foundation has put out a resource on that and is now growing its focus for the very reason that it's asked.
Anecdotally, I can tell you, for certain of our patients that we've had admitted to the Institute, having some sort of a partnership with their priest, pastor, community leader has been really, really effective in certain cases. And we'll have them come to the hospital, meet with the treatment team, meet with the family. It can decrease stigma. It can kind of like put, taking medications or receiving mental health care into a context that is socially acceptable or spiritually acceptable to the patient and the family. So I definitely would agree with that. We've seen some really, really great kind of individual case outcomes, when we can get a good collaboration going. And one thing I just forgot to mention, which you reminded me of, Deb, we actually, at Northern Virginia Mental Health Institute, we are actually in the active planning process of starting our own psychiatric residency program. Believe it or not, there is not a single one in this area. There are only university programs at GW and Georgetown and Howard and Hopkins. There is no community-based residency program in the entire area, and we want to start one. So if anybody's interested in knowing more about that or helping out with that in any way, come find me.
So first of all, I want to thank all of you for being amazing, knowledgeable professionals and for dedicating your life to this cause, which is incredibly important, and for sharing your knowledge with us today. So we did hear some solutions, right? We heard more upstream early interventions. We heard more about continuums of care, and more about primary care providers getting in this game, and more about workforce development. Everybody had a slightly different take on it, but those are concrete suggestions for what we can do as a Commonwealth and as a region to make this better. So thank you, Systems Change Panel. We really appreciate it. Join me in thanking them all. All right, thank you. Yes, please. Now we have a treat for you. We're going to turn to our second panel on equitable access and equitable solutions, and if those panelists could please come join me on the stage. And I will tell you, these practitioners, based on our initial conversations here, have spent their careers focused on more access, more equitable access. They think in an out-of-the-box way, even in some instances out of the system, in terms of how to deliver more on mental health needs. So I'm going to have the pleasure of introducing them now. Come on up, folks. And Claudia. We're going to have Claudia on the screen here. All right, great. Welcome, welcome. Have a seat. Dr. Alfie, hello. Hello, all right, welcome. So let me introduce the panel today. I'm going to start here with Chaplain Tahara Akmal. Tamar is the manager of clinical pastoral education at MedStar Washington Hospital Center, and the program she runs teaches members of the clergy of all faiths how to better care for the mental health needs of their congregants, and the growing demand for mental health services has caused many to turn to their trusted spiritual leaders for guidance and help. Welcome, Chaplain Tahara. Next, we have Dr. Alfie Brenlin Noble. Dr. Alfie is the founder of the Acoma Project that primarily serves people and youth of color, helping to raise consciousness around identifying mental health needs as they arise and finding help to address them once they've been identified. She is also a leading voice around the equitable access issue to mental health services. She's a local leader. She's a clinical psychologist, and we are very lucky to have her. Dr. Alfie is a real powerhouse leader on the issue of equitable access. So Dr. Alfie, thank you for being here with us. And we have Dr. Keith Renshaw. He is the department chair and professor of psychology at the College of Humanities and Social Services at George Mason University. Whoops. There we go. And Keith is also a licensed clinical psychologist and the founder of GMU's Military Veterans and Families Initiative. He specializes in the treatment of anxiety, stress, and trauma, the very needs that, as you saw in the research, we are very underserved on. And he particularly focuses on veterans and military personnel. And finally, on screen, we have Claudia Campos Galvan. And Claudia is the Chief Programs Officer and Mental Health Director at Nueve Vida, which is a nonprofit in Prince William County, one of the grantees of our community foundation that has cracked the code on helping Latinos access the mental health care they need to thrive. Welcome to this panel, and let's have a conversation about equitable access here. So let me start with just a very basic, again, framing question that I'm not going to answer this time. I'm going to ask you folks to answer. What do we mean by mental health equity? And why is engaging in a discussion around mental health equity important? Who would like to take that one?
I'll take it. So one of the things that we talk about the ACOMA project, and I see some of my friends out here, so I'm going to shout out Our Minds Matter because they're trusted partners, and thank you for having me. And for such a lovely introduction, I really appreciate it. So when we think about equitable access to care and health equity, mental health equity at the ACOMA project, one of the things that we say is that every child, inclusive of all aspects of identity, right? Race, culture, immigration status, if they're LGBTQ, a member of that community, if they have a disability, every child deserves the opportunity to live authentically and unapologetically as the best version of themselves. And so for us, what that means is we have a duty to create space for youth and young adults to have what we call equitable access to care. How do you identify mental health problems? How does that look different across racial, ethnic, cultural groups? Everybody doesn't identify these things in the same way. How do we ensure, like my sister here, that we provide them with representatives who look like them, who they can trust, who will share with them, this is a trusted person, you can go see her, she will help you, right? If a person is transgender, if they're non-gender conforming, and they happen to also be a person of color, how do we ensure that the care that they get reflects the best version of who they are and reflects the best versions of the types of interventions that we should be making available to everybody? And then finally, I've been thinking about this a lot. I was thinking about it on the way over here. When we talk about any population, when we're talking about veterans and military folks, my father's a retired Navy guy. When we talk about people, like I said, with disabilities, whatever your ability status is, all of those different identities also have race and culture integrated into them. And so I think equitable healthcare and equity in mental health is really about understanding all of those nuances, all of the intersectionality, and ensuring that the care we provide allows for all of that intersectionality, authenticity, and realness to show up in care. So that's how we define it at the ACOMA project.
So it's a recognition. It's giving a vocabulary to and a recognition that race, ethnicity, sexual orientation, sexual identity, disability perhaps, age, income, right, are all barriers to accessing care. So it's not a one-size-fits-all system by any means, even though it was more or less built that way after World War II, but it's no longer that.
It never was that.
And never was that. Anyone else, including, so Claudia, jump in. We can hear you, and if you'd like to say something in answer to that question.
Yes, yes, right. Thank you. Thank you for letting us know be here and sharing a little bit of our experience in the Latino community. But when we are talking about equity, immediately I am thinking in my community and how the mental health system, or in general, the health system, close the vast gap, because it is a big gap in services and providing all the emotional care that they need. And for example, in Prince William County, it is a very big Latino community, and a lot of them are recent Latino immigrants who face traumatic exposures of migration, PTSD, depression, and stress associated with all the immigration experience, and the challenges of integration here in the United States versus the marginalization of them here in the United States. And how the professional or how the hospitals, clinics, how we close that gap. It is my big question, and it's so important for all of us. If in every single intervention that we are doing in the community, are we close that gap or not?
And we're going to talk a lot more about how you in particular close that gap. So yes, Chaplain Tahara, what would you like to say?
Good morning, everyone, and thank you for the invitation to share my experiences. I'm thinking of connection. One of the things that we as chaplains recognize is those things that we mention can also be places of connection. For example, we often start our training saying a quote that I love: every change is a loss, every loss needs to be grieved. And we talk about how our students, when they come into the program, what have they left behind? So when we go and see patients, we have chaplains, just like a doctor has a history and physical, a nurse has a nursing assessment, social workers have a social assessment. Chaplains have what we call a spiritual assessment. And when we go and see patients, we're looking at, we don't know what they're grieving. We don't know what they left behind to be here. We don't know what's affecting them as a minority. We don't know if the person in front of us has mental illness or not, or even if they're just grieving. That is, depression and grief and sadness. So as a chaplain, we go in kind of normalizing, if we can, that we have a person in front of us. We go in with what we call holy curiosity. We're not there to proselytize. We're not trained to proselytize. We're there to find out what's meaningful to people. There's a very big difference between spirituality and religion. When I think of religion, I think of, that common house of worship. We read the same scriptures or have the same rituals. But spirituality is what brings meaning to people's lives. That could be their pets. It could be the way their body image is. And so as chaplains, we have to go in and be very curious about how any of these dynamics, race, gender identity, so forth, depression, anxiety is impacting them. And one thing we know as a common denominator for all of us in Connection right now is we've all been isolated. We've all struggled and been separated from our loved ones due to COVID and have had fear. Fear to be too close, fear, what if I take off my mask? Fear that my body's not safe, or if I go here or there. So I see it as a chaplain coming in with that curiosity and seeing that we can really connect with people. I'm not much different than the person who may say, I have depression.
No, our shared human experience.
Exactly.
Right? Yes. Dr. Keith.
I'll keep my comments short, and I just think when we think about equity, in my mind, I think a lot of us default quickly to the idea of access, because we know that there's not equitable access, right? Across so many different marginalized groups, and I think there's also this idea of representation, right? Finding providers who can share that lived experience with you, who look like you, who you can connect with on that level. But I want to also sort of point out that a lot of the same factors that lead to things like decreased access are also things that are associated with increased risk. And so even if access was the same, if you want to talk about equity, you'd already have to say, well, we need more supports in these places where there's more risk, right? That's the way. So you almost need to not even think about, well, we've got to make sure we increase access. We also have to increase supports as well, and then the access. So there are many levels, I think, at which we need to think about equity from that standpoint. It's multi-layered, and we can't, I think we have to attend. I think some of us attend to one and some of us attend to another, and that's all fine as long as a whole, the field, right, the group is thinking about all those pieces together.
Right. All right, so I want to ask each of you your take on this. So you each primarily serve a distinct subpopulation. So Claudia spends a lot of her time serving Latinos in Prince William County, and Tahara serves the clergy. Keith serves veterans, and many of Dr. Alfie's patients are African Americans. And not all, but many, yes. And it seems that many people, what you taught me in getting ready for this panel is that many people refuse to access the existing system. They won't go anywhere near it. They know what it is, they know what's in it, and that maybe it could help address something, but they won't use it. So, can you talk about why that is the case and why cracking the code on this barrier is so important to promoting equitable access? Dr.
So at the Acoma Project, what we try to do is create an umbrella that anybody with a marginalized identity feels they can come up under. Because I'm a black woman, I think people often assume, and I don't think it's a bad assumption, but what I always want to help people understand is that when you come to the Acoma Project website, when you look at the Acoma Project social media, because we work with young people, so we're on socials, we try to make sure that I'm always talking with my social media team about make sure you have visibly diverse people in all these pictures. I want a young woman who might be queer and Latina to see herself reflected. I want an Afro-Latina to see herself reflected. I want a Palestinian young man to see himself reflected. I want somebody who's hijabi to see themselves reflected. I want somebody with an assistive device to see themselves reflected, because all of us deserve the opportunity to see ourselves reflected positively. Right? And so for us, this idea of how do we engage people and bring them into care, and what are some of those barriers, I think there are some universal barriers, right? One of those universal barriers is I don't see anybody who I think is going to understand my experience. Right? And what I will say to you is, again, as a Black woman, I work with lots of different kinds of young people. Right? And so I'm licensed in 2 states in DC. I don't practice as much as I used to because I run the nonprofit. But what I will say is the young people who come in to engage us come from so many different backgrounds. But the thing that's shared is they look at me and they listen to me and they hear me articulating something that resonates, right? I'm African American. I don't have the immigrant experience. But I work with folks who do have the immigrant experience. What do we share? Lived experience with discrimination. Right? That's universal for us, right? I may be a heterosexual cisgender woman. What do I share with somebody who identifies as LGBTQ? Lived experience with discrimination and all of the things that impacts. And so this idea of how do we talk about mental health? Everybody doesn't engage in the conversation with the terminology mental health. So what else can we talk about that resonates with people, that allows them to enter into the conversation and have a discussion about depression or anxiety or the downstream effects of being exposed to trauma? And so I think there's this idea of the ways in which I always have this thing I say, just ask people nicely. Right? If you talk to people nicely, they will talk to you. And I think if we allow space, right, and the research that we do, we work a lot with faith communities. We've published with faith communities. When I was faculty at Georgetown years ago in the Department of Psychiatry, we were the first people to bring a pastor, a female pastor, to give grand rounds. It was the first time it had ever happened. And I was floored, like, why hasn't this happened before? And so I think that if we can engage people, I heard somebody on the prior panel say meet people where they are, but sometimes we got to go to uncomfortable places for us to meet people where they are. And I think we're not, as a recovering academic, I don't know that we're always encouraged, no offense, brother, we're not always encouraged to do that kind of work because it's hard, it takes a long time, and so I don't want to get too long-winded, but I think the idea is it really is about studying and understanding and taking the time to listen to meet people where they are. And then, you can't turn every lever, but each one of us can figure out which lever can I turn that's going to allow me to connect in a way to let somebody feel like they can come into care with me. And if they can't come in with me, then I know all these other folks I can send them to. And I think that's part of how we help turn that lever a little bit. Meet them where they are, stay where they are, us being uncomfortable where they are, and then figuring out what are the points of synergy that will allow us to move forward.
Yeah. Chaplain Dahara.
Thank you. When I first started my journey to become a chaplain and then to be certified to train chaplains for interfaith ministry, I didn't know any Muslim women who had done the process, which is about a 4-year process. So I'm connecting that with what my sister said about seeing people before you who are doing what you want to do or are having experiences that you want to have. The traditional idea of clergy has been white, male, Christian, that comes to the hospital or somewhere, the prison, when someone's dying and gives them last rites. So that has changed so much. Chaplains we serve not only in the hospitals, we're in, of course, the prisons, the military, the universities. We're in corporate America. We're at NASCAR. We're in sports. We have pet chaplains, humanist chaplains. We're all over, and we all look different. We come from different experiences. So I think that is, I believe that there's a shift happening with what clergy looks like and how we engage people where they are. One of the things I wanted to share is that some of the data from the Chaplaincy Innovation Lab, I'm an advisory member of the lab, which is out of Brandeis University in Massachusetts, that the typical track for someone to become clergy is to go to seminary, get your bachelor's, go to seminary, and then enroll your master's in divinity, and then go out into parish ministry, do your clinical work, and so forth. So the statistics show in the last maybe 5 years or so, there's maybe longer, a decrease in students enrolling in Masters of Divinity and an increase in students enrolling in Masters in Chaplaincy. And we think some of that trend is that how clergy looks is now representing the communities that we live in and the people who want to go out and serve. So there's another community that's shifting. More people are starting to identify as nuns, not N-U-N-S, N-O-N-E-S. I don't claim Christianity, I don't claim Islam, I don't claim this particular religion. I'm spiritual but not religious. So that's another trend of, what's happening with people. So one of the things we're doing at the lab is looking at that research. But again, as a person who's training clergy, things are changing, and how we engage people is changing. And our education process to become a chaplain is very long. It's almost as long as it takes to become a medical doctor. So in that training,
my goodness.
Yes, you do your undergrad, then your master's at seminary, then you do clinical training in a hospital setting or clinical training, and then you have to get 2,000 hours, and you go for board certification. It's quite a journey.
That sounds like a gauntlet, too.
Yeah, so as things are changing, clergy saying, and the last thing I want to say, and it's unfortunate, but I need to say it, I think one of the reasons why people maybe don't feel comfortable going to their clergy is because people have been harmed by clergy. Around mental illness, around sexual identity, and all of those things. So hopefully our new training will help clergy to meet people where they are, understand, and not shame people with religion.
Right.
So I'll stop there.
Yeah, very, very important topic. All right, I'm going to turn to Claudia now, and Claudia, ask you the same question. You taught me a lot, too, about just rejection of the system in many ways, and the Latinos that you're serving in Prince William County, and the cultural fit that's necessary. So if you'd like to share a story or two about your experience there, that would be great.
Thank you. And just let me tell you that historically, Nueva Vida has had a primary focus in supporting individuals and their families whose life has been affected by cancer. But with this special program named Stronger Together, we go broader about only cancer patients with the intention to support the Latino population in Prince William County, which is the 23%, the largest majority minority community in the county with mental health struggles. And through Stronger Together, we discovered that works very well because it is all about cultural competent services. Our patients resonate with the options we provide for them. We speak their language, and not only we speak their language, we also know the values, we know the culture. We understand very well where and how to present different options, different programs, especially to reduce the stigma for mental health services. We consider and incorporate the focus on religion and family because in our community, the family plays a very important role. And we understand this community very, very well. And we met them where they are. And as Dr. Effie mentioned, it is an invitation for all professionals to go out of our comfort zone and go into the community to help them there, because that is how we can improve their mental health in the community. Going there, not just being at the hospital or being at the clinic in my beautiful office, is going into the community and try to help them, because as we know, the stigma about mental health services is still high in our community. And the Latino community, people are thinking that, well, the mental health services is only for crazy people. And we go directly there and explain them that is not true, that they can learn different techniques for improve their own mental health, or learning new strategies to support their family too. And for that, is very important that we go to the community.
Claudia, when we were getting ready for this event, you were telling me that with your program, which I think is called Stronger Together, right? Nueva Vida goes into the supermarkets.
Correct.
Sets up a table, goes into the churches and sets up a table. The community centers, you're in community. You even told me that when someone stops off at the table and starts realizing what you're providing and perhaps hinting that he or she may need help, you don't even identify yourself as a clinical psychologist.
Correct, because they
now that's
have a
emotional
stigma.
intelligence. I mean, there's something there that you're stopping you from doing that. You're saying, if I lead with that, I'm going to turn this person off. So I'm not going to lead with that.
Yeah, including sometimes I have to dress very according to them. It is like try to maintain myself at the same level of them and try to tell them that they are so important for me. I don't say, hey, wait, because here I am the professional. I just go there and say, hey, I am here to help you.
You make an interpersonal, human to human connection. And the next thing you know, they trust you and they're asking for where they can go for help.
Correct.
All right. Thank you so much for that. So Dr. Keith, what do you have to say about cultural fit? And maybe you've seen it in the veteran community, in the military personnel and their families community.
Sure. Yeah, and I'll talk a little more broadly about that because I do have done a lot of work with the military veteran community, but I think some of the things that you find there, you do, right? You see all kinds of diversity within that population as well, right? There's all kinds of that, and so. But to sort of frame my comments, I'll say, as the white cisgender heterosexual like man on the panel on equitable solutions, a lot of my thinking about this goes to how do I think about the various numerous points of privilege I have to try to advance this issue, right? And I think about this in really, well, in lots of ways, but I'm going to boil it down to two. One is thinking about long-term cultural change. And I mean that in terms of the culture of the country and how we talk about mental health. We talk about how do we crack stigma. There's not going to be a media campaign that gets rid of stigma, right? We're not going to come up with a meme that all of a sudden it's like, oh, it's okay to talk about mental health now, sweet, and now everybody's talking about it, right? So this is going to take generation, really, right? We're talking about, so how do you do this, right? That comes with embedding into the community, right? We've been talking about that throughout. In faith communities, in churches, we talked about schools on the panel before this, we're talking about the grocery store, and we're talking about services there, but I'm saying, somebody said, gosh, we asked the schools to do so much already. I think I shared this in the panel. I have a 13-year-old and a 10-year-old, and the 13-year-old recently completed, I believe it was a 3-week sequence on jump roping in her health education class. Now that's all great, and I'm sure that that's going to help her in life, but why not think about mental health curriculum within that health education piece within the schools? We're not going to ask people to do more. We're going to shift maybe like a week on jump roping and maybe a couple weeks on mental health, right? So I think that there are some real easy points there where we could actually make some significant change over the course of the coming decade, where the younger generation now talks about this stuff in different ways, right? So we have an opportunity here to capitalize on that, I think, and drive it forward. But thinking about churches, thinking about schools, thinking about gyms, thinking about everywhere in the community, start to embed this idea of mental health. Now, what that brings with it is the system, and I know we talked about this in the last panel, and I won't go too long on this, but we have a system that cannot support the mental health needs. We can put all the money we want to in primary care, which is great. I love that. That's a very necessary solution. We can also look at LCSWs, LPCs, chaplaincy. Every single one of these, we're talking about the gauntlet of education and everything else. That is not necessary for every mental health problem. We want to talk about upstream. Let's go a step beyond primary care, and let's get into when you start having trouble. People have no idea where to go because it isn't anywhere. Let's make it everywhere. Yep. So I'll pause on that because I know we're going to get to sort of solutions next, and I've got some thoughts on that.
It makes me think of a question. If we simply increase the raw number of licensed mental health professionals, do you think it's going to meaningfully address this issue of cultural fit? Or do you
No.
think it would be, or do you think it would be, see, I told you they're going to have a different point of view. They have a different point of view. Would it be more productive if we simply trained existing, in addition to trying to, well, of course, we're going to try to train up more professionals, but also train existing professionals to help them better address the cultural fit, to get the kind of skills, ideas around listening, meeting them where they are. Is that a worthy endeavor?
So it's a worthy endeavor. I think the struggle is, that's part of the reason I'm a recovering academic. I think the struggle is we have to start even further upstream.
Yeah.
Who leads training?
Yeah.
And why in this moment in time, if you're a counseling psychologist, I would say you get a lot of this. If you're an MSW or in social work or nursing, I would say you get a lot of this kind of training and discussions around systems, right? And how systems interact with race, culture, ethnicity, all points of identity. If you're, I'm just gonna call us out.
Yeah.
Other
That's why
kinds of
you're
psychologists or psychiatrists, you're not getting this. If you're lucky, you get one semester. One semester, and this myth that pervades, that drives me nuts, because I used to teach it, that people assume cultural competence means you know every single thing about every single culture. That's not what cultural competence is. Cultural competence is an undergirding framework, knowledge, skills, and awareness. The Sue brothers literally wrote the book. Right? And so predated by a lot of other folks, Chester Pierce and some of these other amazing people. But the idea is if we increase the volume, what we're really doing is just increasing the sheer numbers of what already exists. And so to my colleague's point, it's really about starting from a place of how are we even training people? And I'll say this one thing because it kind of sticks in my craw. It's this idea that if we keep throwing money at training programs, well, we can train up more Black and brown and Asian and Native. We can just train more. But you're still not dealing with the systems that people go into with these marginalized identities and get pushed right back out because it's too uncomfortable. And so we have to, you know, on their side, right? This mental health, the providers too, the researchers, all of these folks. So we have to create a system. You want to increase equitable access. Let's talk about how we inculcate discussions and comfort and ideas around race, culture, ethnicity, all these points of intersecting identities from day one in training. I think that will help because you're doing two things at once.
Just rethink the way mental health professionals are trained.
Yes.
And so if I could follow up on that, what I would say is let's think about who we're training. We are not going to solve the mental health crisis of the country with MDs, PhDs, and even quite frankly, more masters. It's not scalable. The solution, and we could, billions of dollars can get poured into it. That's not going to solve it. It's also not necessarily needed. So if you're not familiar with it, check it out at some point. There's a guy up at Harvard, academic, who's named Vikram Patel, and he's done work since the early 2000s, training up lay folks in villages in India in some evidence-based but fairly straightforward behavioral strategies for dealing with anxiety, depression, etc. And it works. You don't have to train for 6-7 years. We need people doing that too, because you need, but what you're going to need.
Sort of at the top of the pyramid.
Yeah,
right?
you need stepped care, right? There is no way to address this without some sort of model at which there's a base entry level of people with some really basic resources who are culturally humble and responsive and understand they're never going to know everything about another culture, but they need to understand another person's culture to be able to help them, who also have some basic skills that they can give a person who can then begin to address some of the problems they're having at an early phase. That kind of thing needs to be easily accessible everywhere. You can train lots of people to do that, and I can tell you, given being in a clinical psych program, seeing the hundreds of applicants who apply for 5 or 6 slots, there are people who want to do this kind of work. They just can't get the training. They don't need that level of training, right? And then you can start to scaffold it. You can embed that kind of work for people who do some really entry-level stuff with folks who are also trained to identify when people need more, and then they kick them up to a slightly higher level of care where you've got a couple of sessions, a few sessions with maybe your master's level trained person, et cetera. And then if that doesn't work, they enter the system that we're all talking about here. That might be a scalable model.
Can I just add one thing? And I want to, Sister Tahara, because I will monopolize easily, because this is my favorite thing we'll talk about. So I just want to, with respect, sis, okay, I'm sorry. The one thing I would just add, with respect, my brother, When we talk about evidence-based, evidence for whom and under what circumstances. 100%. So I just had to throw that in there. I can expound later, and if anybody cares, I'll stand over there in the back. We can have that conversation. I don't want to like monopolize the time, but I'm always cautious when we start talking about evidence-based. And that's all. I think a lot of people know what I mean, but that's all I'm gonna say. I'll wait till the end, because I could do that for like the next 20 minutes.
Okay. Chaplain Tahara.
I'm seeing two layers in my mind. So the first layer I'm seeing is when we talk about the system, I'm just going to use racism. The system is what is harming and causing mental illness. For example, as a Black woman, as a Muslim woman, the gaslighting that I experience when I hear racism doesn't exist, for God's sake, you had a Black president, and all these things, the pain and the suffering that I and maybe others feel when I'm fearful, post 9/11, after, what happened. It just, how we're impacted by different systems of oppression and systems of hatred. So I see that as one layer. So how do we address, I remember, I got to say this real quick, I used to work at a hospital in Pennsylvania, and I would put, in kind of rural part of Pennsylvania, and I would put in my GPS to go somewhere. And sometimes Waze would take me through rural Pennsylvania, and my heart would start beating, and I was fearful. I said, if my car breaks down as a Black woman, as a Muslim woman who wears hijab, I don't feel safe. So these kinds of things that we live with every day, how does the system address that? And the system is a part of that. The other layer I see is caring for the caregiver, mental health of the caregiver. So we know through COVID and working in a hospital, we've been on the front lines. So the mental stress and harm that we've been through, all of us who've been on the front lines during COVID, how has that impacted us? Maybe we haven't fully seen that yet. How has that impacted our mental health? So that we have people who we're identifying might need help.
We're just starting to see
and
that.
we're just, because I even know for myself, it's been really hard. And so, and I'll talk about solutions later, but we've done some things. So I see those two layers.
Yep. All right, Claudia, I'm going to start with you on this next question. And I think we've already in some ways addressed it, but it's almost like the whole service paradigm, what you're talking about is flipping the service paradigm. So let's talk a little bit about modes of service delivery. The system has always required, if you will, that those in need of mental health services go and find a provider, right? Find the provider, go to the office, get treated. But each of you seem to have found a way to flip that paradigm. You're not sitting in the office waiting for the patients to come to you. You're going out into community and helping people find their way to the help that they need. Yeah. So, so talk a little bit about that. It almost sounds like a whole disruption to me, a disruption of an industry. In a way, maybe that's overstating it. What would you say about that, Claudia?
Through this specific program, Stronger Together in Intervention in Prince William County, we provide them workshops or group discussions to help them to increase the awareness and education about mental health. Stronger Together goes to the people who needs help. We position ourselves, as you mentioned, in supermarket, community centers, churches, laundromat. And we ask them like simple questions, because we also provide services for reducing risk of cancer. And we ask questions like, did you get your mammogram or did you get your pap smears? And we start the conversation with them. Some of them, we help them to refer them to a free mammography or free pap smears. But at the same time, we invite them to participate in this specific program, Stronger Together. And we go with them and we act like as a bridge between the community and between the services, specifically the mental health services in the community. We see every single person like a holistic, like holistically, like a complete person, not only their head or what is happening in their mental health. We also provide other services that they can improve the general health, but we normalize the mental health with them. because as you mentioned before, I never said, well, I am a clinical psychologist. I just say, hey, I am here to help you. And we start gaining the trust on them, because when we are in the community, one of the very important keys is that the community trusts on you. If they don't trust on you, they don't open anything. But if you are there and you give them empathy and you give them the trust, they open for everything. We receive a lot of calls that is not related either mental health or health in general, but they call us because they trust on us.
Right. I mean, it seems to me that just the gesture of going into community is you're setting yourself up for trust. You're saying, I'm going to go there and help you, right?
Correct.
That very gesture itself is engendering trust.
Correct. And it's very important to mention that during the pandemic, it was impossible to have easy access to mental health services into the community. I remember some of our clients that mentioned that when they go and ask for seeing a mental health provider, they say that they have to wait 8 months for treatment. And when we start listening about that, we create a Stronger Together, like an answer of this crisis, because the community needs help. And when they go to the community clinic and try to find it, they don't have access.
Right. You were saying in the beginning, Nueva Vida started being an organization that was helping cancer patients, but you evolved to enter the mental health realm. So thank you. All right, Dr. Alfie, what do you have to say about flipping the paradigm?
So one of the things I would add to Dr. Claudia, who I don't think she remembers me. I know her from Dr. Christy Graves and some work that they did years ago that was funded by PCORI. So, hola, Claudia. So I think, three things we talk about, which is directly related to what Dr. Claudia just shared with us. And that is, at the Acoma Project, we believe in raising consciousness, empowering people, and changing the system. Those first two, I think, are right? Because if someone never gets in front of a mental health provider, one of the things that we talk about is when I or any of our subject matter experts go out, always leave people with something, right? And one of my favorite things is leaving people with mindfulness and meditation, right? Free, portable, right? And so a lot of times when I'm with particularly Latinas and African American women, I say, when you're at work and that person has just worked your last nerve, this is how you support yourself. Get up, go to the bathroom, and just do this deep breathing exercise that I'm going to teach you.
Yeah.
Right? When you're home with the kids.
So self-care on a daily basis.
Exactly. And practices that you can use, to your point, self-care, right? Just how do you regulate, modulate, how do you recognize what those symptoms are, and then how do you care for them?
Yeah. Dr. Keith, what do you have to say about flipping this service paradigm?
Well, I'm scared to think about deep breathing as an evidence-based strategy, but I'm scared.
I think it is.
No, I think this is spot on, right? I mean, this is exactly what we're talking about here. And you mentioned disruption at the beginning,
yep.
And I could imagine current providers going like, whoa, because don't disrupt my system, right? This is my job, and it's not like if you disrupt the system in a way where we start bringing mental health care to people as opposed to sitting around waiting for them to come get this wonderful care that we have, all of a sudden people are going to be out of a job. We have tons of unmet need. We have millions of people with unmet need, right? We have to find a scalable way to address this. There are two issues in my mind. Well, three. Well, whatever. There are probably 78. But so one is we have a deep lack of culturally informed, culturally responsive, evidence-based practices that we need to address. Two, we have a whole range of mild to moderate conditions that are quite impactful, quite distressing, both personally, interpersonally, societally, economically, etc., that can be addressed with fairly straightforward strategies that do not take 4 to 8 years of training and supervision and everything else. And this is somebody, I just woke up to the idea of a qualified mental health professional, which is this whole designation in Virginia, a couple of years ago. I had no idea it existed. My first reaction was sort of, oh, no, this is terrible, and then I realized, wait a second, maybe not, maybe this makes sense. But even beyond that, right, there are some straightforward strategies that we can bring 2 people. Then, if we're doing that and we have people who are trusted in the community, talking with other people, helping them out, and then if they find they need more, you've already gotten over that first step of thinking about accessing care because you're in the middle of it. It just happens to be where you are in your community with somebody you know who is now telling you, I think you might benefit from a little bit more. Can I help you connect you with someone? Right? So I think if we start to think about it that way, the system still exists. It's not disrupted, it's not blown up.
No,
but there's a whole new level before it.
But you mentioned to me again in one of our preliminary conversations, you've been a licensed clinical psychologist now and you practice, right? You still practice. And you said something along the lines of, I used to wonder, how come if there's so much need out there, more people aren't coming in?
Yeah, that was big. You know, my work with the military and the veteran community, I think that was a big thing. You know, it's like, we've got such great treatments for these things. Where are all the people? Right? We know they're out. You know, they're not coming to us, right? And so we have to go find them, right? I mean, that's what it's about in my mind.
But also, we think the treatments are great. We don't know what they think about our treatments.
No, absolutely, solid point.
Tara.
The way we bring community in the hospital to patients is that we walk in and say hello. So we train our chaplains to go in and to do what we can to empower patients. And these are patients in different units. You know, we have mental health units, but we have all types of units. And we recognize that our patients are vulnerable, and we try to empower them by giving them choices. Because they can't tell the doctor no, they can't tell the nurse no, they can't tell PT, OT, they're being told what to eat, when to go for tests. So as a chaplain, we try to meet them where they are. And when we walk in, I kind of joke with students, we say, you know, if you get kicked out, think of that as the ministry of getting kicked out the room. You empower them to say, no, chaplain, I don't want you. They can't necessarily say that to others. So we try to bring community by empowering our patients. We bring community by asking them, you know, how are you? Who's thinking of you? Who loves you? Where your loved ones? Oh, these are beautiful flowers. Who sent those? And really trying to build a relationship and that trust with the patients and bringing their community in. Pre-COVID, it was easier to bring their own clergy or a representative in to see them if we could. It's a little bit different now. It's a little bit more difficult, but we can still do it, especially at end of life. But that's how we try to bring community to our patients.
Yes. Mm-hmm. So I could spend the last question asking you something that I think most of you have already answered, which is if you had to change something about the existing system, what would it be? So instead, let me ask you something different. And the first panel didn't get a chance to talk about this, but there's always been a tremendous amount of stigma around mental health and seeking mental health services. I mean, I was hoping that just this data around the massive size of the need could actually help take down the stigma. I mean, depression and anxiety looks less like something that we need help for. It looks more like a feature of being human. You know, it's like having brown eyes. I mean, a lot of people have brown eyes, and a lot of people are depressed right now. Maybe that's just wishful thinking, but I think if you can get the data out there about how extensive this issue is, it could help with the stigma. But you've all also taught me that stigma is alive and well and is a huge barrier to the equitable access of care. So I thought we'd talk a little bit about stigma. Do you think it's growing? Do you think it's diminishing? How do you manage it?
I would like to start.
Yes, go ahead, Claudia, please.
And I just want to mention that our team tries to overcome this barrier through conducting psychoeducational workshops in the community. We invite our population to learn tools for life, such as learning techniques to manage stress, depression, improve family relationships, and little by little, we are bringing them closer to the mental health system or services. And many of them open up their experiences of pain, trauma, suffering, and give us the opportunity to intervene with them to improving the quality of life. But it is step by step. It is not going with my hat of professional. It's going to the community, having this type of psychoeducational workshops and invite them to open the heart and open everything that they have to give us. That is in our experience.
Yes. All right, who would like to talk about stigma? I know, it's a huge issue.
What I've been finding in caring for the caregiver, I'm finding that people are more open to talk about what the last 2 years have looked like with COVID. And maybe that could be an opening to more authenticity in how we share with our friends and family members when we're not doing well, instead of saying, oh, I'm fine. But I know, like, professionally, I've been excited that more professionals have sought out care for the caregiver. Through the Chaplaincy Innovation Lab, we've started what's called conversation circles. So these are for chaplains of color who want to meet for peer groups, and I and a colleague will facilitate the groups, and they get to talk about what it's like, oftentimes as being the only Black chaplain in their system, or some of the experience of discrimination they've experienced. So people are, I'm finding, more vulnerable and open. And I don't know if that has to do with COVID or stigma's going down, but I'm excited about what I'm seeing.
So
authenticity.
You're saying you're particularly noticing this with the caregivers, yes?
With caregivers, yes.
So do you think it has to do with just this common experience or this common trauma? You can call it a trauma that we've all been through with COVID.
It's a trauma, yeah. It could be. Yeah, I think it has a lot to do with that. And hopefully it's a leveling, we'll have a leveling effect, and then maybe we see that we're not that far away from maybe our patient.
This isn't an issue for someone else. This is an issue in my life.
It's affecting me and my family.
I think when I think about it, and I go back to some stuff I was mentioning earlier, I think it's important to think about how do we think about the broader community, and and how do you engage in community level change, right? So now I'll hearken to a quick example from the military community, right, where they have started to try to really amp up the publicity around higher ranking officers talking about their experience of PTSD, talking about their experience of suicidality.
That's huge.
Those are big pieces. Yep. It hasn't solved the problem,
but it helps,
right? So I think that's a piece of it, and I think when you think about how do you change culture, right? Where is culture, right? Culture's at home, culture's in the community, culture's in the media, right? And so we need to be thinking about in the community, right, at all levels, right? So school, education, churches, community organizations, clubs, social clubs, sports, right? All these kinds of things. Where do large groups of people kind of congregate, and how can we embed things about mental health, mental illness in those sorts of organizations? And then finally, when you get to the level of media, right, I mean, you're thinking about sort of popular media, and you're thinking about news coverage, right? And so you see, I'm sure the American Psychiatric Association is doing this. I know the American Psychological Association is working with, trying to reach out to news organizations, national and local, about how they cover different types of issues. You see sports figures coming out and talking about struggles with mental illness. Those are those are culture shifts, right? How do we capitalize on that? How do we promote that? How do we work with people who want to do that to give them, language and, ways of talking about things that can sort of help move the needle? And then how do we work with our state legislatures? I heard there's a senator somewhere in here, in terms of like embedding this into health curriculum.
And I think this data is an opportunity.
The data is absolutely an opportunity.
We now have some music here. The event's not over, so that's not what that's signaling.
They're telling us wrap it up.
We're getting towards the end, but no, it's not the walking out music, okay?
I feel like we should all be in an elevator.
Thank you, all right. So Dr. Alfie,
so
talk
I think
a little bit about
the only thing
stigma.
I would have to add to that is the opportunities in media, and I'm going to speak specifically to young people, right? And in my definition, I'm Gen X. So my definition of young people is pretty much anybody under 40. So with that said, I said young people, I didn't say babies, I said young people, so out of respect. But I have 2 teenagers in my house, 15 and 17. And so I learned so much paying attention to what they're into, and then that becomes leverage for how I engage the young people that we work with. So to your point about media, I'm thinking specifically of people of color. So when I think about people like Selena Gomez running a whole organization, Rare Beauty, and she has this whole council of all these, like every name you can think of, superstar in the mental health profession, in the field, advocacy, everything. That gives young people an opportunity to see talking about mental health is okay. We did a film with Lady Gaga back in November the number of people who still talk about that. But I'll tell you what was special about it. She's done a lot.
She's using her fame.
She really is. And even as a white, heterosexual, cisgender woman, the fact that everybody you see around her has so much intersectional identity representation, that allows young people, again, to have a place to come in and say, oh, it's okay to talk about mental health. So one of the people in the film was a Filipina, transgender, immigrant woman from the Philippines to the US. For people to see her, right? For people to just look at her and have her talk about her own struggles with mental health, that's powerful because they can put a face to it. I mean, I think the other thing in terms of media is watching all of to my brother's point, the athletes, right? Naomi Osaka literally stopping a match or getting to the end of a match and just talking about her experience at Indian Wells, right? Yeah. And how different her experience. Think about the arc. Venus and Serena stopped going because of how racist and awful the people were. She's there and she's able to articulate. So I think it's this trajectory, this arc, where people now have a teeny bit more space. But what I will say that's a little different is going back to generational differences. While it's opening up, I say a lot for millennials, Gen Z and Gen Alpha, I still think there are struggles around stigma for Gen Xers and older. And I think that some of our work is really helping Gen X and older folks feel comfortable entering into this conversation because our kids, sometimes siblings, grandkids, nieces and nephews, they're able to have the conversations and be a little bit more open, but it's still a struggle for those of us who are older.
Yeah, I think the more we hear about it in greater culture, the less it's a thing, it's the less of a barrier it's going to become, right? It's just a feature of being human. This happens.
And I just want to add that
So listen, some of you may have some questions. Yes, just one second, Claudia. I'm going to call on you right now. Some of you may have some questions, so please start writing them down on your cards, and Community Foundation staff will come around and collect them. We're going to have some time for Q&A for this panel as well. So Claudia, what else did you want to say about stigma?
I just want to add that we have to take advantage of all this new era for apps. For example, young people are in TikTok, are in Instagram, and all these sources. And it is a big opportunity for us to educate them there, educate them against stigma, for example. Right now, I am doing reels on Instagram, like a short videos educating for different topics. But it's so important that we have presence with the young people, and we have to adapt to all that new generations, because in our old generations, you never go to social media, for example. You have to be very, very careful with all the social media and everything. It's like a panic when a mental health professional is going to social media. But in my opinion, it's so important that we have to take advantage of social media for educate the new population or the new generations.
Can I just mention, and to her point, there's two I want to mention that people in social media: Latinx therapy, Asians for mental health. Those are biggies for me. Brown girl therapy. Those are all three different that really represent well the spectrum, I think, of people of color across generations on social media, giving them real good advice. So those are three that I really love.
All right, great. Yes, we've got some questions here. Let's take a few. Okay. Okay. Yeah. All right. Give me a moment here. Okay. How can we talk to others about cultural barriers? Some colleagues don't trust the health system due to historic events, and mental health is a deeply generational stigma in the community. So maybe this is a question about how do you start the conversation?
I'll just add one resource. So in 2020, I published a book, Community Mental Health Engagement for Racially Diverse Populations. What was unique about the book is all of the chapters had to be co-authored by people with lived experience, stakeholders, and traditional academics. That was a requirement. And so it makes the content accessible. So that's one. Another thing I would say is there's this wonderful resource, and this is specific again to young people and young adults, called Sound It Out Together. It's sounditouttogether.org. It's a resource from the Ad Council. I'm telling you, it's fabulous, where they have music videos. And the music videos, the first iteration is focused on Latinx, can be of any race, and Black African American, Black Caribbean, Black African young people, where they have these music videos that were created to help parents and caregivers enter into conversations in a culturally competent way with young people around mental health. So those are just 2 resources. And they have a caregiver guide that has STEM questions. So I think showing people those kinds of resources that are sort of, like you said, it makes it part of the human experience.
Right, it's just in the environment.
It's just normal, it's just
right.
there.
It's right, it's not just something that you only hear about in hushed tones off in a corner somewhere, you know? Thank you. All right, anyone else on that question?
The only thing I would add is one of the things we do when we're training chaplains is looking at ourselves first. You know, when have I struggled with mental illness? When have I felt deep sadness or depression? So just starting with ourselves and, you know, tapping into that vulnerability and then reaching out and maybe starting to have conversations with people you trust.
I think that's the key. That's the key to empathy, right? You see in others what is already in that you already know is in you.
Right.
And so you can already empathize for that person because you hope to get the same grace directed towards you, right? So I love this question. Basic question. What is the best thing to say to someone who says, quote, I'm depressed?
It'll be fine. No, I'm just kidding. I mean, to me, it would be to simply say, tell me what's going on, right? I mean, I think that a lot of people, I think sometimes what happens is, you know, when you hear somebody use the word depressed, right, you know, or something like that, and you get this mental health, you get this thing like, I've got to connect you to a resource. But first, let's understand what the issue is. You know, I mean, sometimes it's a situational stressor, sometimes it's a thing going on, and sometimes a person needs that personal connection. I'm not suggesting that people then start taking on therapy on their own, right? You know, but simply to add, like, you know, tell me what's going on, you know, or I hear you, you know, yeah. So that's I don't know that that's the best answer.
So you would respond first with a question that says, tell me what's going on, to get them to talk more about it. Okay.
And I love that somebody in the chat add, you are not alone.
And you are not alone.
Yeah, and that is so important to make feel that person that is not alone suffering with depression, and normalize that person can speak about it, and we have a community to support you.
What a great point. You know, it brings me back to that stunning statistic that 1/2 of every adult between the ages of 18 and 30 in Northern Virginia have clinical levels of depression or anxiety. That's the 3rd time you've heard that this morning, but it's worth repeating. 1/2 of everyone in Northern Virginia between the ages of 18 and 30. I said this to my primary care physician a couple of weeks ago, and you know what he said? That sounds about right. All right, here's one more question. How can peer support be better integrated within the continuum of mental health care?
So what I would say, I hear a lot of talk about peer support, probably in the last 10 to 15 years, including like peer navigators, right? People love collaborative care. I know Jurgen Eunicer very well, and all those folks in Seattle, and we've talked about collaborative care and the wonderfulness and its limits around race and culture. And so what I would say in terms of peer support is I think as part of a system of care is critical, and at the same time, and I think what's really important is ensuring, I'm just gonna stick with this cultural competence piece, that in the context of building peer supports and having people, there's something called Teen Line out in LA for some colleagues that I'm very close with. Andy Reamer is their CEO, and they train teenagers basically to run a mental health hotline. To me, that is peer support, and it's really important, but I know that there are different variations of peer support. So the only thing I say is it's critical, it's important, and even in that context, we still always want to make sure that how we're providing support for people as they get integrated into being those peer supporters is that cultural competence is key. And I would reflect on my sister here, this idea of, as part of the training, reflecting on our own lived experience and how do we build from that lived experience to inform what we do. So it's important. Right. We just always want to be thinking about cultural competence.
Because Tahara, that's what your training is for clergy. There's a lot of peer support going on there, right, in the training that you provide.
Yes, it's a lot. It's an adult education model where we have small groups of, we have residents and interns at Washington Hospital Center, at MedStar, Washington Hospital Center, and they're given feedback. They're able to share their emotions. They're able to, be vulnerable in the group. So our residents are with us for a year. So they build that peer support and that trust. One thing I would add is, I like what you said about, maybe somehow having the peers understand what to say. If someone says, I'm depressed, not to say, oh, you'll be fine. Those things. So making sure peers are
Don't brush it off, right?
Yeah, are equipped to be curious and find out what's going on. But yeah, peer support is very important. We started doing that at Washington Hospital Center, partnering with our National Rehab Hospital and having some conversations about difficult topics like racism, what was happening with the African American community and the police force, and so I was really excited that the hospital sponsored that for us. So having those kind of conversations aren't always easy, but I think they're important.
Yep.
I'll just add two things. I think you said it well. I think it's about helping people understand how to sort of normalize without minimizing, right? There's this like, lots of people are depressed, right? It can go the other way, right? If you overuse that. So it's normalizing, not minimizing. But the other piece I'd say is just ideally, in my mind, because I agree, peer support is a fantastic thing to embed in some of these lower levels that that I would advocate for. I think it's critical to also make sure that people understand how to identify when someone needs more than peer support, because it's going to help a lot of people and it's not going to necessarily be enough for everyone. And so I just think that piece of knowing the limits is really important within peer support.
All right, and we have 5 minutes left of the panel. So I thought I would leave with this idea that came up at the last panel about holistic thinking around the treatment of human beings. The mind and the body are not two separate things. I mean, people with mental health disorders can become physically ill, and people with physical chronic ailments can become mentally ill. And I've seen both happen in my life, right? It's clearly the case. What do you say about a system that is so bifurcated the thinking around the mind and the body? I mean, from someone who's never been trained in this system in any way, shape, or form, my background is the law, not medicine, it seems odd. It just seems strange. So wondering if you have some thoughts on that, about how we can better just address the holistic needs of a human being, and what the system would need to do to get its head and its arms around that.
Literally and figuratively, yeah. So
say that again?
I said literally and figuratively.
Literally and figuratively,
so
right.
For me, some of the guidance is coming from, now I will say this, I'm like a lunar eclipse. You're only gonna see one every 100 years. I'm a Black Catholic. And so part of it is, but I work in Black Protestant communities. My spouse is Baptist, and we are an ecumenical family. That's what we're gonna say, because people say you're confused. No, it's ecumenical. So working with Black faith communities, in my prior life, I was a psychiatry professor at Duke, and so in the Durham area, there's a large Black population. Long story short, for me, what I learned working in Black faith communities is that there is a holistic approach. And so for me, that's some of my guidance around how do I conceptualize a whole body, right? And so when you talk about, like, your body is your temple, and I know that's translatable across different faith perspectives, that then becomes a lot of guidance for me around how do I enter into these conversations about mental health, right? So, for example, the way it shows up clinically is when I heard somebody say this on the other panel, when I'm talking to a parent, I can remember so many times, particularly with Black and Latinx, Latina parents, having conversations about meds for the kids. I'm like, no, absolutely not. And I remember learning and having conversation with one of my colleagues, and the colleague said something to me, and I've always remembered and always used it, and that was, if any other physical thing was wrong with your child, you would do everything in your power to give your child the best opportunity to heal. We want the brain to have that same opportunity. And every time I say that to a caregiver, they like burst into tears, like, absolutely, I would never want to, have this, like you said, bifurcated approach. And so for me, it's that idea of all of it is a gift. If you're a person of faith, your whole body is a gift. And so we want to take care from head to toe of your whole body. And that's how I enter into the conversation. And I find that super helpful. Now, that doesn't change the system, but it certainly informs how I do my work.
But it changed your approach to your patients.
100%.
I think for me, it's medicine itself is somewhat, so we could talk about holistic and we say, I think a lot of it though, if I go to the doctor and I have a broken leg versus I'm not seeing right, they're going to send me to two different people, right? Who have had different training.
Well, there's that too.
So there's a lot of separation within the medical field, within specialties. That said, I think it's a lot clearer where to send people for most other things. Like they know, okay, we're going to send you to the osteopath, or we're going to send you. The eye doctor, the whatever, right? And they know it's going. You either need like the medical doctor, eye doctor, or you need the ophthalmologist. So they have that set up. Then you get to mental health, and it's like, well, there's referrals, and maybe it's psychiatry, maybe it's a clinical social worker, maybe it's a counselor. There's a lot less clarity within that space, and I think that's where the breakdown happens. So I think integrating folks into primary care, because primary care is the place where you do see a lot of the integration, right? Or internal medicine or whatever, you can think about that. So making sure that it's incorporated there.
And there seems to be more people going into primary care.
Yeah.
I think that's a trend because they like the idea of holistically approaching a patient.
And yet you still, if you've been to see your primary care doc, it's not like you're sitting down and having a nice long chat about everything going on in your life, right? You're waiting an hour because they're running late and they got 20 minutes for 10 minutes. And, so there's a challenge there to just rely on primary care completely. But I think if there was a clearer delineation, I also think there's a whole thing with the integrated primary care movement of there are two ways of doing it. One is embedding mental health care into the primary care doc, and one is putting a psychologist or a counselor in the doctor's office and then just having them operate as usual. And I don't think that technically that works. I was just talking to somebody in the audience earlier who was saying, we're on like an 8-month wait list, for my doctor's office, right? It's like.
So let me ask you this. Not that long ago, say mid-century, doctors were probably in the pendulum swing way over here. They did everything. Some things well, some things not so well, but they did everything, right? Now it seems like the pendulum has swung entirely in the other direction. You got a specialist for everything. But I'm seeing that pendulum starting to go back a little bit, where people are looking at the profession more holistically, wanting to treat human beings holistically, thinking, I've got to think differently about this. Maybe I'm imagining that, wondering if anyone on the panel is seeing that.
I would just add that you see that with palliative care. So with palliative care, you're looking at the person, their family system, the family dynamics, their faith tradition. So you're caring for them and giving them comfort care or managing pain and looking at their whole life dynamic and what would be helpful for the family, not just the person. And one of the things, just really quickly, that we've done with medical students at one of my other hospitals is we wanted to meet with medical students early in their training and to talk about spirituality, because the data shows that a high majority of Americans will love for their PCP to talk to them about their faith or spirituality. Yep. And so one of the things we did around sensitive end-of-life care is, and I think you just did it a little while ago, for physicians to be mindful of the word "but." And when giving difficult news, for example, if the data shows things don't look well, but the family's very spiritual or religious and they're holding on for that miracle.
Right.
To navigate that conversation with kindness, and maybe if it's congruent with the physician's values and understanding, to say something like, yes, I hear you're holding, you're waiting for this miracle for your son, and can I share the latest medical report? Let's see where we are here. Because if you say but, it's just gonna, now you're in a tug of war with the family and God and all this. It's just so if we can approach medical professionals earlier to say, how do you incorporate holistically the family and everyone in the care, and
Right.
Don't forget the spiritual piece.
So Chaplain Tahara, you've got the last word. Our panel time is up. And I want to thank all of you for an incredible discussion on equitable solutions and equitable access to the mental health care system, really. That was absolutely terrific. Thank you, Claudia and Keith and Dr. Alfie and Chaplain Tahara. So I just want to thank everybody today. I mean, this is a tremendous program. All of our speakers, Dr. Regina James, who has stayed and watched the event, thank you for being our keynote, and Elizabeth Hughes with Insight Region, and all of our panelists, including, not just this panel, but Sandy Chung and Darcy Grodadaro and Deb Oswalt and Naveed Rashid. Thank you, Drew Wilder with NBC4 for not only emceeing this event, but for taking such a personal interest in telling the story. I want to thank our 17 presenting partners. We had 17 anchor institutions in the region who joined us today on this event. Every one of you are institutions of renewal for Northern Virginia. You are actively seeking a path forward out of the pandemic into better and healthier times, and we are so proud to call every single one of you friends and partners and colleagues. So the Community Foundation for Northern Virginia is actually in the midst of a campaign to build a forever source of critical support for the mental health needs of the region, especially for those who struggle the most. And the campaign ends this Friday, and I was just handed a note here that we are 96% to our goal, so that's very good. So your gifts of any amount would be so very, very gratefully appreciated. And we are going to take the money that this campaign develops, and we are going to build a significant endowment for the needs of the mental health needs in Northern Virginia with this as our seed funding. So I thank all of you, who I know many of you here have already been donors to the campaign. This concludes our 2022 Shape of the Region Conference. Thank you all so much for coming. Thank you all to all of you online who have been listening, for engaging, for asking questions, for being curious about this topic and ways we can make Northern Virginia a healthier place. We will see you all again next year at the 2023 Shape of the Region. Have a great day.